Good afternoon, everyone, and welcome to today's CME. I'm Dr. Sri Krishna, the Secretary General IAP Twin Cities branch, and a warm welcome on behalf of the Executive Board of IAPTCB. Today's CME is very special because we're seeing seasonal diseases day in and day out, and diseases which have a common presentation of fever, plus minus, cold, cough, body aches, headaches, but then the diagnosis is confusing us. We have three major disorders, dengue being the predominant, little of COVID, and also MISC. And to tell us more about how to distinguish this, how to manage, and also come to a rational decision making and management, we have an esteemed faculty to discuss these aspects in today's CME. I now invite Dr. Tilak Chandrapal sir, very senior academician, to chair the session. Tilak sir, for your inaugural remarks, and then we straight away go to the session. Please come over.
Good afternoon, all of you. I thank the IAPTCB for giving me this opportunity. Now we are in the middle of the whirlpool of the pandemic of COVID-19. I think we will come out of it successfully. We are between the second wave and supposed to happen third wave, which may coincide with the vaccination of the young ones. So what we have learned all these days, so it will be summed up by Dr. Dinesh Chidla. He will what is the present situation of the COVID-19? Because the seasonal disease also started with the monsoon, and there are mix and match various infections occurring together, and how it is going to approach these children also will be dealt with. I will be joined by Dr. Bhaskar, who will give address. Please.
Invite President-elect Dr. Sunkoj Bhaskar sir for his inaugural remarks.
Good evening, all. At the outset, I thank IAPTCB and Team Rainbow for giving me this opportunity to co-chair this session along with Dr. Tilak Chandrapal. I feel it's a privilege and honor to me to chair this session. And my sincere congratulations to Rainbow team and IAPTCB for taking up this pertinent, relevant issues for today's session. And my personal experience, most of our intensive care cases with fever, it has become routine to do SARS-CoV-2 antibodies. Though we suspect dengue or some other viral infections, we are seeing lots of IgG elevated titers in those children. But most of them are not very critical. They don't have multi-system involvement, but some of them, very few of them are having dengue with MISI. And I think I'm sure Dr. Dr. Dinesh, Dr. Farhan, and Madam, they can demystify about all those things. They can share your knowledge and skills to us so that it would be very useful to practitioners like me. But amazingly, we are seeing less number of SARS-CoV-2 active cases, but more of dengue with the MISI, not exactly MISI, some other MISI, but IgG are positive. Then I realized when data from Mumbai and India, 65% of our children are already exposed to the virus. With these few words, I request the organizers, I invite Dr. Dinesh Kumar, the Director, Pediatric Intensive Care Units, Rainbow Children's Hospitals. Please come over to the dais and present your presentations. Thank you.
Good afternoon, everyone. And I take this opportunity to thank IAP Twin City to yeah. Give this opportunity to Rainbow Children's Hospital to host this very important topic. And thank you, Chairperson, for the kind introduction. Now, what have we learned over the last sort of 1.5 years or close to 2 years now by this December is specifically if you look at the data from India, we see among the COVID positive cases, if you look from the Ministry of Family Welfare, less than 12% for the children who are less than 20 years, they constitute 12% of the total positive cases. Though we constitute 41% of the population, so only 12% are positive. If you look at the deaths, among the total number of deaths, only 2% of the deaths are among less than 20 years. So, which basically says the number of cases which are positive in children are less and they are less severe. This is what we could learn from the first wave and second wave. We also could see that the MISC has been seen not only in the developed country but also in our country 2 to 6 weeks after the peak. This has been demonstrated during the first wave and also in the second wave. So why was there was a lot of hangama about, in the second wave, there's an increased number of children. So if you look at, we had 2 different types of peaks. We almost had at a peak time, almost 4 lakh reported cases per day in the second wave. And if you take 12% of those cases, that is the reason the percentage of cases among total didn't change. But since the number of cases positive were increasing, that's why more children were positive. So that is the reason why the second wave, we all felt that more children were positive. So what are the challenges to pediatricians this season? And what should we expect in the third wave is the most. See, I think there have been a lot of, from the time one of the virologists has made it saying, the first wave we had older person, the second wave it is more of a middle age or the young, slightly younger population. The third wave it will be predominantly children. I think we have a lot of, not only from the media, the government, has been alert that all the children's hospital, all the government sector has been extra alert about trying to get the resources ready for the children for the third wave. We just talk whether it is going to be really that the children are going to be hit that hard and what is being already been seeing in some of the developed country. But what is already we are seeing, most of us are seeing is, we're seeing fever for other causes, and that is what they're expecting in other countries also. The children have been indoors for very long, now they're coming out, they're being exposed to other viruses, and that is how do we differentiate fever from other causes from fever because of COVID? Fever because of dengue, fever because of flu, fever because of enteric, fever because of MIC, how do we differentiate? This is what let's address. And of course, I'll touch base on diagnosis and management of MIC, and also how do we differentiate between MIC and acute COVID. Now with the third wave, what is going to happen is most of the adults are going to be vaccinated. And possibly the school and colleges are going to reopen. Maybe end of September or October, that is what it is. This might lead to increase in the number of cases is what is the postulation. If you look at some of the data from US, there has been increase in the number of cases percentage from 12 to 14%. They have seen in some of the states increasing to as high as 24% to 20% in some of the cases as children contributing to the total number of positive cases. So there has been some rise. We are seeing in the news that some of the Delta variants are being positive in some of the states in US, and they are filling up children's hospital. But mind you, these were the states where the vaccination drive was very poor. So what might be expected is we might definitely see more cases in the children, but whether we really see the sick ones, I think if you look at the pathophysiology about how the COVID, it needs the AC receptors to actually sort of attach, bind, and then sort of enter the alveoli and cause the damage to the alveoli. So for that to sort of happen, and to initiate the cytokine response. Since the number of AC receptors are less in children, and since the cytokine or immunological response is less in the children, it's very unlikely that we are going to see a very severe one unless there's a immune dysregulation or some mutation in the children in the virus. If you look at the pattern of the way in the first wave and second wave we've seen, in the second wave we saw a rapid rise and rapid fall, unlike in the first wave, there was a gradual rise and fall. Even now, in the last week, yesterday and a week, we saw almost 31,000 cases per day, majority of them being reported from Kerala. Worldwide, still nearly 21 crores cases have been reported, more than sort of 3.1 crore from India, and have been reported as far as COVID positive cases. Now, when we look at the data, when you look at how the virus actually works, the first phase, it's a viral phase, stage 1, where the early infection is there. And then as the virus, the pulmonary phase starts, the inflammatory phase starts increasing. Whichever patient has a hyperinflammatory response, that is when they actually go into ARDS or cardiac failure or in shock. So you'll have significantly, even in adults, where 70 to 75% of them have mild to moderate disease, because they do not show that phase. If you look at one of, I think I missed on one of the data, the children are the one who do not show so much of this hyperinflammatory response. They are the one who show the late inflammatory response or multi-system inflammatory syndrome. This is sort of what is unique to children. Now, what has been sort of done from all this evidence which we gathered over the last 2 years? So this is a nice sort of diagram, sort of which has sort of come up from Ministry of Family Welfare. So which divided, I think, a lot of us over the last year have learned about how to do teleconsultation. That is one thing which we have learned what COVID has taught us. So if you are asymptomatic, I think 2 things: no need to investigate, no need to get the child to the hospital. The only way we sort of tend to get them diagnosed is because they come in contact, you are part of the family screening, they got positive, and in them, hydrate them well, tell them the danger signs, and then monitor them at home. So there's no medications which has been, if you look at the whole list in this blue, there's no medication which has been prescribed as per the Ministry of Family Welfare. So really, that is what we need to sort of stick to the minimum. Even if you look at the mild, and this is about the COVID preparedness in the third wave. And this is the data which is sort of, the booklet which has come up about how do you prepare for the third wave. So the government is going to come up with the COVID care centers also. So again, as far as possible, keep them in home isolation only. Keep them in home isolation. Only the places where home isolation is difficult, then only keep them to COVID care center, give paracetamol for fever. That is the only medication, and coughs up, to manage the cough. That is the only thing which has been described in the green thing. And again, no investigations been suggested in the mild sort of group. Then comes interesting from what we have learned in the moderate and the severe. What you have seen in the moderate is any child who's requiring some oxygen to maintain the saturation above 90%. That is what is a moderate group. These are the children, and then you have an age-specific respiratory rate. If your respiratory rate is more than that, then you say. So they are the one who had to be admitted in the COVID-specific hospitals or private. The government expects that 60% will be in the private sector and 40% probably will go to public sector. That's sort of the ratios what they think. And it is in this group they would say monitor the temperature, give oxygen, and look at here. There's no rule of routine steroids. There's no role of routine steroids is what has been again sort of mentioned. And one thing which has very prominently has been recommended is remdesivir is something which the government has said no use for remdesivir. So this is one controversy which has come up. And if you look at some of the guidelines from RCPCH and other things, they have not actually taken this off and say it's still under emergency consideration. If you look at an emergency use authorization drug is not recommended in children. And if you look actually remdesivir, when it was originally sort of licensed, it says not for children, but somehow CDC has authorized it for emergency purpose. So again, routine use of remdesivir is absolutely no. When it comes to severe, a child who's requiring some degree of respiratory support, child who's in shock, who's admitted into the ICUs. They are the two things which we have to talk about. So again, in these two groups, you might have to give antibiotic based on what you're suspecting as per the unit protocol. Manage the ARDS based on the ventilating requirement. You again, low tidal volume, not use too much high tidal volume. But again, no remdesivir. Steroids, I'll talk to you about steroids. And again, there is a clear guidelines about what to do with the anticoagulants. So steroids are not indicated and harmful in asymptomatic or mild cases. Should not be given in acute viremic phases. Should be given under strict supervision. Should discouraged against self-medication. Do not give on teleconsultation. So the one which has been recommended is dexamethasone, 0.15 milligram per kg, 6 milligram, maximum of 6 once a day, or methylprednisolone, 0.75 milligram per kg, maximum 30 milligram once a day. Give for 5 to 7 days. Some would say that, some would taper it off. This is for mainly for children who are moderate and severe, who are rapidly deteriorating, especially I would say someone who are requiring respiratory support. Anticoagulants, again, unlike adults, are not routinely prescribed to children. They're all hospitalized patients should be monitored for thrombosis or suspicion, confirmed by appropriate investigations. So I think what we all have realized that a lot of time D-dimers are coming elevated in children very routinely. So do not plan your this thing just based on the D-dimers. So is this child at risk of thrombosis is what you need to look into. And based on that, we need to sort of see, is this child to administer anticoagulants must be balanced with the child's bleeding risk. And children already on anticoagulant therapy may continue the same unless they develop active bleeding. The one which is recommended is enoxaparin, 0.5 milligram per kg twice daily. Or if you have thrombosis, then give 1 milligram per kg. So these are two things which are little different from what we do in the adults. ARDS, I would say, yes, if your PIP requirement is very high, crossing 28 to 30, that is when you should consider high frequency oscillation. Try prone position in intubated patients, and consider ECMO if you have refractory hypoxemia, that is your OI is more than 30 to 40, and you have severe LV dysfunction. Now, this is interesting, is what this thing about, very safe, very useful, harmful, and not useful. Now, these medications have moved over a period of time. I think this is one COVID-19, every time you lecture, you have to adjust this medication because the data goes on changing. So we had to really adjust it, because plasma therapy was once on that side, now it has moved on to the left. Similarly, remdesivir, I didn't know where to keep it. I just kept it in the center because it's controversial. So I said, just keep it in the center. So what is really useful is awake protein, oxygen therapy, and steroids. That is useful. But plasma therapy is out. Remdesivir, again, controversy is there. Tocilizumab, really, I think biologics will talk about it, especially those in cases of, who are not responding, and you have a cytokine storm. That is when we start think about, mainly in MICs, we think about that. Pulse dose steroids, again, in children with sort of, shock, who are not responding to sort of regular IVIG. Again, no role of azithromycin and hydroxychloroquine has been clearly said. Again, vitamin zinc, probably not useful, but they are safe. The other thing which we are commonly seeing is MIC. Now, definition, probably age is slight in CDC says less than 21 years, and WHO says less than sort of 20 years. And one thing is common is fever of more than 3 days, fever of 4 days. That is one thing is there. So your child should have fever. That is one thing you should think. So that is most essential. Then should have at least 2 of the following. That is either conjunctivitis or mucocutaneous inflammation, hypotension or shock, features of cardiac dysfunction, evidence of coagulopathy, or GI abnormalities. So you can, when it comes to cardiac dysfunction, you can have pericarditis or valvulitis or coronary artery abnormalities. Not only, so you will have any of these things with elevated troponin or pro-BNP. Elevated markers of inflammation, that is ESR, CRP, and procalcitonin. And no other obvious microbial inflammation, including bacterial sepsis, staph, or streptococcal shock syndrome. So nothing else is explaining this. I would say for our India purpose, you should add that dengue. You should add dengue is not explaining the shock, is what you have to say when you're writing the MIC. And there should be some evidence of COVID, either exposure, positive set of antibodies or RT-PCR should be sort of positive for us to say that is MIC. Because now what happened is earlier when we said MIC, we were talking about only of severe MIC. But nowadays we also are seeing MICs which may not be severe. That is what people have started also using the term of febrile inflammation syndrome. And that is what I'll try to talk about, those scenarios which we are seeing in clinically, and we need to find answers for that. So if you see among the SARS-CoV-2 infection in children, less than 1% of them actually develop MIC. Most MIC cases have occurred in older children and adolescents compared to and they're usually healthy, and usually time frame is 2 to 6 weeks after the. So why does it happen? It's usually immune dysregulation. So after exposure to the COVID virus, so you have an interferon response. So if suppose the virus load is there, the interferon will come and try to clear. But sometimes there is an abnormal immunological response, like the way you have in Kawasaki or macrophage activation syndrome or cytokine release syndrome. That is when you will have features like MIC. The way the myocardial injury happens is probably either because of systemic inflammation or could be acute viral myocarditis as part of your COVID, or hypoxia or stress cardiomyopathy, and rarely ischemia because of coronary artery involvement. So what are the symptoms which we normally have? So one thing is 100% everyone will have fever. 90 to 100% everyone will have fever as part of MIC. And usually fever, we start thinking about MIC only when the fever is more than 3 to 5 days. That is when we start about fever. Second common thing is GI is one thing which is supposed to, very commonly. And if you look at the percentage, nearly 80 to 90% of them have GI symptoms. Could be vomiting, loose motion, pain in abdomen. This is something. A lot of us are seeing patients, children with vomiting, loose motions, and pain in abdomen. And if you do ultrasound, some of them have terminal ileitis also. This could be MIC. But do you say anyone coming with vomiting, loose motion as MIC? I think if they don't have persistent fever, you can't. If they don't have raised inflammation, you won't be able to say that. So I think that is where we have to get it right, because it becomes very difficult to differentiate between them, both of them, unless we get it right. Other is cardiorespiratory. So shock is one thing. So not all MIC present with shock. That is again a message. Because now anyone coming with shock, I think give immunoglobulin, give steroids. So now some may, in fact, only 65% of the patients of this might present with shock. And they can have poor cardiac function. They might have sort of pericardial effusion, and they on echo. And when you do a measure troponin level and pro-BNP level, they're very high. And also we have, someone is scribbling. How can that come? So, and as far as as far as neurocognitive, so listen, very interesting is we have close to 15% of the students who can present neurological symptoms, altered sensorium, seizures, and acute necrotizing encephalitis type of patients. So also could be a symptoms of this, and they can do very well when you give them sort of immunoglobulin and steroids, and that is what we need to sort of realize. Oh, this got locked up. Okay. So shock 32 to 76% based on some of the studies. Mucocutaneous finding, like what you see in Kawasaki disease, red swollen lips, strawberry tongue, 27 to 76%. Criteria met for Kawasaki disease only between 20 to 64%. Myocardial dysfunction is by echocardiogram and elevated troponin level only 51 to 90%. Arrhythmia and 12%. Acute respiratory failure requiring non-invasive ventilation between 28 to 52%. Things like acute kidney injury, psoriasis, hepatitis, and nephropathy are seen in very less number of patients. So MIC can be in these three categories. Either they are no category one is no shock, no Kawasaki disease. Mainly they have high fever and raised inflammatory markers. Second is you have high fever, but classical features of Kawasaki. You have mucocutaneous features, dilated coronaries on the echo. So that is a category 2. So MIC with Kawasaki disease. And the third is MIC with shock, where you do not have features of shock. You do not have features of Kawasaki disease, but have shock. So they come with hypotension, respiratory failure, very, very sick with multi-organ involvement. So you can have any of the three. The third one are the one who got sick ones. Sometimes you can have overlap where the child with acute COVID is going into second week, third week, can present into suddenly a MIC-like feature. So how do you differentiate? So most of the MIC cases have occurred in children who were previously healthy, whereas most cases of severe acute COVID occurs in children with underlying health problems. So some comorbid conditions are there. Children with MIC may have a history of known or suspected COVID-19 infection in the weeks preceding to onset of febrile inflammation. The pattern of organ system involvement also differs. So if you look at only severe pulmonary involvement like pneumonia, acute respiratory syndrome is a prominent feature in a COVID, acute COVID. Whereas if it's MIC, you'll have mostly cardiac, more of a shock and a cardiac problem. Myocardial dysfunction and shock are more common in MIC than in severe acute COVID-19. GI symptoms are again more common in MIC, and mucocutaneous findings are more common in MIC. Inflammatory markers like CRP, ferritin, and D-dimer tend to be more elevated in MIC compared to severe acute COVID-19, in addition to lymphopenia and thrombocytopenia. And SARS-CoV antibody titers are higher in patients with MIC compared to the acute COVID-19. So this is how you saw it. So what are the investigations which will help us to? So one is, if you look at CBP, you will have lymphocytopenia, you will have neutrophilia, mild anemia, thrombocytopenia. This is the percentage in which you sort of might present. All of them have elevated markers. CRP is high in most of them. ESR is high in 80. Mind you, ESR is not a good marker to know the progress of the disease, because once you start them, give them immunoglobulin, ESR is not a gate marker to see the progress of the disease. D-dimer, fibrinogen, ferritin, procalcitonin, and interleukin tend to be elevated. Troponin and BNP are elevated for patients who presented with shock. Echocardiogram findings, you can have depressed LV dysfunction in 50 to 60% of the cases. Coronary artery aneurysm, especially those who are presenting with shock. Coronary artery aneurysm in 20 to 50% means abnormalities, dilated or aneurysm, and valvular abnormalities and pericardial effusions can also be noted. And low albumin level, elevated liver enzymes, elevated LDH levels, and triglyceride levels are also seen. So we don't have to get all the magnifier was there, no? Magnifier. It's coming bigger in mind. That's why I didn't do. So sorry about this. So this was actually a flow diagram about how you should go about in a patient who has presented with MIC. I was able to actually magnify it a little bit more. But so I think, question is, if a child presents already with shock and MIC, like you have high fever, presenting with okay. That's fine. I think it's lost its clarity, no? Okay. So I losing it. Fine. I can tell you what it is. Huh? Oh, I put and this fine.
Anymore we can't see.
I think it's so. I think I can tell you the gist of it. So if you're having fever, raised inflammatory marker, and with shock, you can go to Tier 2 investigation straight away, which means apart from doing your CBP, CRP, your electrolytes, urea creatinine, liver function test, you can also go for your pro-BNP, troponin levels, LDH levels, D-dimer levels as part and echocardiogram. So this is sort of what you say, go for your tier 2 investigations for children who are presenting with primarily these things. Suppose you are presenting with primarily with fever and you are having raised inflammatory markers, but there is no shock. So look for other causes of raised inflammatory. Look for other causes of infections, like you're having, is this staph, is this staph, is there anything else which is cause for raised inflammatory markers? And if they all are negative, then you can continue to look for evidence for MIC in these children. Like an echo can be done. And if the fever is persistent, send a SARS-CoV antibody in them. If SARS-CoV antibody is persistent, fever is persistent, and there is a rising sort of inflammatory marker, that is when you may have to sort of consider MIC in this. So I think I'll be able to cover this in little detail in the next sort of slides. If this is not clear, okay. Okay, so I think the bottom line in the past, first, your fever along with raised inflammatory marker is one which will help you to differentiate which line you have to go. But before you label any patient as MIC or not, you have to rule out all possible other causes. You rule out your dengue, you rule out your rickettsia, you rule out your enteric fever, and then sort of say that this is MIC or not. That is one important. If you're having a child with a shock, then again, of course, you get an echo done. You have an echo showing dilated coronary arteries, or you have a mucocutaneous features, very classical, and you have definitely SARS-CoV exposure and COVID antibodies positive, then probably you will have a lower threshold to confirm that it is a MIC. So as said earlier, you have 3 MIC with shock or multi-organ dysfunction. Other is Kawasaki, and third is without shock. The one with shock is there. You have to give immunoglobulin, has to be given to them, and IV methylprednisolone. There's not a lot of controversy about only immunoglobulin as first choice and the first line of treatment, and give steroids as a second line of treatment. But there is more and more data coming up. If you use both of them together, like steroids and immunoglobulin together, the LV function improves faster, the child's duration of respiratory support improves, the mortality is less, and so most of people are going on to combined treatment. So IVIG with steroids is what sort of, that is the reason why Ministry of Family Welfare has recommended to give IVIG plus steroids as your first line for those with a presenting shock or multi-organ dysfunction. If still symptoms persist beyond 48 to 72 hours, then that is when you may have to consider pulse dose of steroids. That's when you have to consider pulse dose of steroids and consult the specialist, that is, which is sort of pediatric immunologist or rheumatologist, and that is where we may have to consider things like, biologists, either it could be tocilizumab or anakinra is what sort of we are sort of looking at in some of these patients. Now, if you have a Kawasaki, classical Kawasaki disease, which is you have conjunctivitis, you have mucosal involvement, and you have high fever, an echo showing coronary artery dilatation, then you go for IVIG and methylprednisolone. Most of them do respond to that. And if the child is still persistent to have fever, then you next try. So earlier days, if you remember, we used to go for a second dose of IVIG if the child is having a refractory to sort of, IVIG. But now, if you look at the newer recommendations, if you're not responding to IVIG 2 grams per kg, the rheumatologist would have a lower threshold to go to biologics if the child is not responding. So the same thing has been coming into Kawasaki recommendation also. The third is MIC without shock, which is what we're talking about, like a febrile inflammatory syndrome. You have a child with fever, it's not responding, has high inflammatory markers, then a methylprednisolone of 1 to 2 milligram per kg would help in a lot of these children, and they tend to sort of respond much better with this. Here, there's no role of immunoglobulin. This is a very busy slide, and I can share this sort of, this has been developed from a couple of our consultants from Bangalore, which gives you all possible sort of, headache, meningitis, seizures, non-critical conjunctivitis, lymphadenopathy, nausea, vomiting. These are the clinical signs that the child can present. And then you say, based on fever for more than 24 hours, you say, check if the child has COVID on exposure or not, and do the serology. And based on this is a summation about, like, very specific to India, sepsis, toxic shock syndrome, enteric fever, rickettsia, and other viral infection has to be ruled out. if the fever is more than 7 days. If these are negative, then only start thinking about, and at the same time, we had to rule out some of the autoimmune inflammatory condition and malignancies. So we'll talk this again in details when we're talking about in the our panel discussion. So in some of the evidence which has come up so far, this was some of the experience which has come up from US children and adolescents with MISC. And in what they found that 52% of patients had SARS-CoV-2 PCR positive, 45% had COVID antibody positive, and 31 were positive for both. So I think it is based on, and we found we had 109 children with MISC positive at our rainbow, and we had similarly 33% were positive for PCR, and 64% had antibody positive, and we had 14% who were positive for both. Hence, it is important for us to differentiate between acute COVID illness and MISC. What are the factors which indicate the severe outcome in MISC? At a retrospective surveillance, again, has come up in a very important in Lancet. And what has been found that age older than 5 years was strongly associated with more severe outcome and ICU admissions. Coronary involvement was more in male in patients. And terminal pro-B type of brain natriuretic peptide, that pro-BNP and IL-6 concentration were significantly associated with coronary artery abnormality. And the likelihood of shock was significantly associated with almost all of the other factors: elevated D-dimer, troponin, BNP, pro-BNP, and CRP, ferritin, and IL-6. We usually found anyone presenting with shock have all this significantly elevated. So this was data from our 109 patients. And we found that if you look at category 1, 2, 3, third is the one with in us who are presented with shock. And we found the children who presented with shock, they were slightly older. The male dominance was there throughout, which we have seen. The duration of illness more in that group, in the shock group, and the PRISM and SOFA score was more in those children. Same thing. And what you find that rash and conjunctivitis is more in the children with Kawasaki disease, whereas hypotension and encephalopathy was more seen in children who presented with shock. The other thing which comes is, and these recommendations, I didn't get a standard recommendation from anywhere, when to do echoes. See, that is one thing. And and those who have interacted with cardiologists, they would find saying those who have MIC-like feature, your initial echo has been normal, and they say they have come back after 2 weeks with giant coronary artery aneurysm. That is what sort of, if you speak to Dr. Naishar, he says, because he sees a lot of them and he says that comes back. So one message is, even your first echo is normal, get the repeat echo after 2 weeks is what has been recommendations if you have a classical MIC. If you have a coronary artery dilatation or aneurysm, then the frequency of repetition, I've seen some recommending sort of do it weekly. Some would say every 3rd day, but see till you get it back to normal. And based on the size of this thing, if you have a Z score more than 10, then you may have to give enoxaparin, or the size is more than 8 millimeter, you have to give enoxaparin, otherwise aspirin is fine. Again, if you have systolic dysfunction, based on the type of dysfunction and your inotropic requirement, you'll do a repeat echo. But if you have coronary artery involvement and systolic dysfunction, that is when you have to do a MRI of your heart at around 6 months of the age. So what are the scenarios which we have facing as clinicians? One is vomiting and loose motions and abdominal motion. If you have a straightforward case, then we don't have to worry. We don't have to think about MIC. But if the same patient has fever which is persistent beyond 3rd day, 4th day, that's when we should start doing blood tests in these children. If they come with high inflammatory markers, then maybe some of them you do stool examination, there are a lot of pus, treat them with antibiotic, they get better, no need to worry. But we are finding some children who are not getting better by end of 1 week, still having high inflammatory markers. The other children, I think I would say, so you don't necessarily have to have shock for us to start thinking. So this is one scenario, I think as a clinician, we need to start thinking about. The second is fever with shock. So you have a classical rash present, dengue with rash with NS1 positive, shock on day 2 of illness. You have a contracted disease process. We talk about it in the panel. But if you have a rash, which shock? Is it a dengue shock or is it an MIC shock? Is something which we'll talk in the panel discussion. But if the rash is absent, then how to differentiate whether it's acute myocarditis which is causing cardiac dysfunction or it is MIC causing myocardial dysfunction. So there, I think the inflammatory markers help, and the COVID exposure to COVID and COVID antibodies help us to sort of find out whether we need to treat them as an MIC or not. The third scenario which all of us are facing is child presenting with persistent fever not subsiding, 8th day, 9th day, and you can't find any focus. Earlier, a lot of children, we used to probably treat them on the line of autoimmune disease. We used to probably have systemic onset JRA and other things. But here the child has COVID antibody positive and he has persistently high. So here, is it COVID, is an innocent bystander, and still it is a systemic onset JRA? We do not know. And this is something which is very, very common, we are seeing. And also, how do we differentiate this, some of them, from malignancy? This is one problem which a lot of pediatricians are going to face. But I know we are already seeing so many cases where fever persists beyond 1 week. So we have to rule out autoimmune conditions. We have to rule out all the inflammatory conditions before, especially if a child is otherwise well with not much involvement of any other organ, only with fever, raise inflammatory marker. But this, so this is something, sort of dilemmas all of us are going to face. And also in MIC also, the one scenario which we are facing is going to be MIC is perfectly diagnosed. We treat them, we given them IVIG, they respond, but after day 4, day 5, they come back again with fever. So how long to give steroids, whether to continue with steroids, and whether we sort of, repeat the course of immunoglobulin, when to give biologics. This is all what sort of, I think, we can discuss in the panel. I just sort of just put that for the thought, so that this is what I think is the burning problem which all the pediatricians are going to face over the next 6 months. So I thought, let me open for discussion. So thank you again. Thank you all. Thank you, sir, for giving this opportunity.
So So next topic is by Dr. Farhan Sheikh, the Director of the Critical Care, Rainbow Hospital, on severe dengue, recent advances in the management. The questions you can send on the chat box, and they will be discussed at the end of this topic.
Thank you. Sure. Can you see my screen? Sir? Yeah, please.
has been, is there any way to know coronary artery dilatation when there is no echo vessel? Or in a way, is there a way in which you can predict any of them would have probably come up too early to you or might come up too late? And it happens especially on the vessel. What I'm saying is, cardiac involvement cannot is it probably a better way to answer that question? Because coronaries are very specific.
Screen orange.
That needs echocardiogram. Even with echocardiogram, I say I need a good cardiologist to tell you.
But yeah, full screen चले जाओ when your chance comes.
Long capillary field, peripherance and the pulses, your drop in the blood pressure, white blood pressure, narrow pulse pressure. The child has got high fever and high inflammatory markers. We say that the child that is one thing which you can do. Second thing which can be easily done.
Hello, sorry. I hope I was audible before. I say, see, coronaries are something which you need an experienced person. But definitely a cardiac involvement can be assessed by clinical examination and some blood test, which can be done at periphery. So clinical examination would be your pulses, your blood pressure, and blood pressure, whether you basically look at wide pulse pressure or narrow pulse pressure, and of course hypotension, prolonged capillary fill, whether it is extremities are cold. These are some good clues which will tell you that there is a cardiac involvement. The second part which definitely sort of would help you would be, I'm sure most of them, because troponin is something which adults do very frequently because that's how they pick up the MI. In adults. So troponin levels you can do, and proBNP may be available. This is another way which you can do a blood test which will tell you whether there is a cardiac involvement, because they are significantly elevated in all the children who have a cardiac injury. So yeah, so that's the best way for you to sort of identify any child who has come with MIC who has features of cardiac involvement.
Yes, actually, there is one recent study published in February 2021, where Moses Adams, where he has said that proBNP is a marker which predicts the coronary dilatation after a few days. So if your proBNP is elevated and if your coronaries are normal, then you are supposed to do a 2D echo, even though your coronaries are normal after 7 to 10 days, then you will catch that coronaries are normal. Will get dilated eventually. And we have one case actually in first floor who had a normal coronaries and proBNP was elevated. So because proBNP was elevated, we repeated a 2D echo after 3 days and it became dilated. Although the fever was not there, but coronary became dilated.
I want to so this cocktail of
presentation ये ना फुल में जाना है क्योंकि यही दिखाई देगा ये
The monoclonal antibody is available, sir. The recommendation for
regular
that is
view
for
में जाता है ना
adults.
there's a mode called presenter view screen में चलो हाँ आ गया अभी एक बार अभी screen था ना
risk factors. It is not yet licensed for children. So, but it is available. It costs 1.2 lakhs, but in 1.2 lakhs, 2 people can get treated.
नहीं अभी आपने बताया था ना उसमें स्क्रीन बोल के देखा था स्क्रीन चलो नहीं
so a lot of people who are able to
use slide show
60,000 or something, suppose they are going for it. And
अभी आप स्क्रीन शेयर अभी zoom करके
going beyond third wave. So if somebody is positive for COVID in the past, so what are the things one has to
perfect
But इधर ऐसा आ गया
after say the case comes
next slide चलो
COVID positive 1 year back, 2 years back, you are expecting what
the question was, if someone is
there's
COVID
actually a
positive, what are the
more
possible
presenter
problems which you might expect in the future? Or suppose if you have come with the past history of COVID antibody, is there anything which we should look for?
Use
Or we are
slide show.
anticipating in future reports? That is asking very excellent
वो कर
question.
तो उधर चला
Sir,
जा
I'll tell you. Now, this is what we are facing. See, some of us are
इधर भी आ गया
seeing some of the children with dengue presenting early with shock. This is, I know one of the theory is immune paralysis or augmented immune response is something is if child got exposed to COVID, there has been some immune response, then again got exposed to another viruses, so the child is having a dysregulated immune response, and that's why probably they're presenting with shock. That is one thing. Having said that, in children, unlike adults who are having a prolonged phase of recovery, or like in lungs, they're having fibrosis, or they're having persistent tachycardia, and those type of features, children do not have, because the alveologenesis and other things is a continuing phenomenon in them. So the recovery in them is very good, even in the severe. And third is whether they have children who have been very sick, who are been ventilated and other things, whether they have any neurological behavioral abnormality is something which people are looking into. I think we'll have to look into that. But of course, this immunological concern has been raised. Yes, we'll have to. We do not know at this stage, I would say, but it is immunodysregulation is something which we'll have to look for in future.
I've already posted in the chat box. Sir, Dr. Dinesh, I had a patient with cervical lymphadenitis. Can we think this is as an initial presentation of BC in this child, because subsequently turned out to be a BC? So, is cervical lymphadenitis, are you seeing as an initial presentation feature?
Cervical lymphadenitis, the first essential point is fever. So having
fever is their bottom.
Fever for more than 3 days, 4 days is one thing. Isolated cervical lymphadenitis without glucose involvement, without GI symptoms, without any other thing, it's difficult to label this, but we only come as one organ. You need to find second organ to say that say as MS. But if you say yes, you have we have some patients who have something called as incomplete MIC, or this is which is called febrile inflammatory syndrome, is a term which is being used, where you have persistent fever, you have some small lymph nodes which are being there, no other focus. That is what I'm saying the scenario. No other focus. Earlier time used to probably say as whether they are systemic onset GRA, we used to think like that. ANS can be negative. Cholesterol markers are coming, but your ESR is raised, your CRP is raised, all the effective markers are negative, your tuberculosis is negative, everything is negative. They are the children who are responding to steroids of 1 to 2 mg per kg by second and third day.
Suppose the serology for our COVID is also negative. Can we still label them as a post?
Sir, I either see what is saying serology is not compulsory. Either you should have RT-PCR positive, serology positive, or exposure history. One of the three has to be there.
Given exposure history without having a RT-PCR or a serology.
Has to be there. Without any three, then it is going to be very tough to say.
Exposure is almost there.
Okay, Dinesh, you mentioned that 85-90% cases procalcitonin will be positive in case of MIS elevated. When it is known that procalcitonin is a specific marker for bacterial infections, then how do you?
Procalcitonin is at one stage in the beginning we thought we got some magic bullet which will differentiate between bacterial and viral, but it has lost that thing. It is not anymore. It is like any other inflammatory marker. It can go up in other inflammatory conditions also.
Yes.
See, sometimes it will go procalcitonin is golden 100.
Yes.
And then it starts coming down.
Without there being blood culture positive.
Yes.
So it's again a marker of inflammation.
It is a marker of cytokine storm.
Yeah, one last question there. One observation on my assessment is MISC is a diagnosis of exposure. High index of suspicion in our during this pandemic is the key, especially when I'm running a level 2 center. So we need to have that in the back of our mind, but we cannot have everything as MISC and then
Yes, true.
Especially
Particularly in sir case, what he is saying about lymphadenitis, it will be very risky. You can miss a leukemia or lymphoma. So it's better to go do a biopsy or a bone marrow at least and make sure that you're ruling out a malignancy and other thing before starting steroids.
All autoinflammatory and malignancy, if you look at the chart, it says more than 7 days, do not autoinflammatory condition, will not malignancy.
Because sir, 60-70% of population is now antibody positive. So
And most important thing, I've seen particularly MISC has been very common in obese children. Right now, there's a classical MISC and dengue admitted in rainbow.
Yes,
The fellow mountain with high fever, very obese kid, is almost 75 kg something.
Yes, sir.
And sudden temperature second day only. But clinically, I thought it was only dengue. Hardly shock. And there was no history of money. History way back in May.
2 months back.
April, May only.
Yes,
Exposure. And as Dr. Dinesh says, exposure in the family itself is good enough. You not have a documented COVID positive. Dinesh, one question. Why only coronaries? Why not renal arteries or cerebral arteries? I mean, any particular predilection for coronary arteries?
Yeah, as we said, you know, with the prediction for the myocardial injury because of
pathophysiology. That's the reason I put that things about pathophysiology. Myocardial injury is known either through the antibody stress inflammation or hypoxia, and that is the reason why. Like the principle is very similar to the cardiac cases, and that is the reason why. I think probably because of the way the blood supply and other thing is there. That's the reason why the coronary artery dilatation is significant there. What happens at the micro level, not sure, but three things is immune dysregulation, macrophage activation. These are two things which happens at this thing. See, one thing which you rightly pointed out is what we are seeing also is a lot of use of steroids as a first line, a lot of use of IVIG. Just considering this, so we need to rule out all the conditions before labeling as MIC. So as you rightly said, it is a diagnosis of exclusion because now when 2/3 of your population is COVID antibody positive, so don't diagnose MISI just because you have got COVID antibody positive because it could just be innocent bystander. So you have to rule out that the child doesn't have any of that because sometimes you might be caught up wrongly with other diseases.
It was exactly opposite in April. April, everything was MIC, but now we need to rule out.
Dr. Dinesh, last question. I hope we'll move on to dengue and again come back in the panel.
Yes.
For a mix of
In panel, we'll discuss.
Two questions which parents have asked for, which I don't have an answer. For those where the family has got affected, especially in the second wave, is there a way you can predict or have some kind of warning that this child might have MISC? One. Second, how long do parents have this fear? Let's say the child was COVID positive. Now this child is just 2 years, 3 years. Till after what age can they really feel kind of secure that, okay, this danger lurking is not going to happen to my child?
See, the MIC, if you look at 2 to 6 weeks is the common time when you can get MIC post-COVID exposure. So I think the maximum you stretch is up to 8 weeks. That is what I tell them. So if you cross 8 weeks, unlikely to have MIC. That is the first thing. The way the prediction is, people look at neutrophil lymphocyte ratios. That is one thing. So you have a significant lymphopenia in your initial blood reports and other, I know.
So you're mentioning the time when they had COVID.
I know that is one of the way I'm saying there's no, see, normally, do you look for it? You don't look for it. But when you remember, I showed you one of the studies which says you which are the patients who can have a significant MIC and other things. So the markers for significant MIC have been the neutrophil lymphocyte ratios, thrombocytopenia, and raised CRP and inflammatory markers. So in absence of that, if suppose a child had a is very difficult for anyone because the number of children who had COVID, who develop MIC is less than 1%. That's what you can tell the parents. So only 1% children develop. So whether your child will fall in 1% or not is going to be difficult to sort of, is a very straightforward answer, as I would say. Unless you have some blood reports to say some of these things, they say we just observe them. But I don't see there is any test or any result which is there to predict that your child will have MIC or not. I'm not aware about any such study. Only in MIC which predict the severity, there is some studies. But there are none to say when you first get COVID, can you get MIC or not? We don't have studies. If that's what you're asking.
Yeah, that's the question most of the families have asked.
You can't predict that.
I think it may be viral clearance also, sir. Because the patient which you sent, sir, that was 3 months back, child had COVID. And the COVID PCR which we sent, CME is still showing some viral traces. Although the CT value is high, it is 42. So I think if the viral clearance is late, then the MIC also can happen 2 months after that viral clearance. So if the viral clearance is early, then maybe MIC will occur early.
That is one of the theory about how MIC happens. Those who have a delayed viral clearance, they probably have a higher interferon response, and that's the reason why they can have. Is one of these. But I'm not aware about any study which says if your CT value is this at the end of week, you have an MIC. There are no studies to say. Because we don't normally repeat the CT. Another thing is that I think please, there's no role of CT chest in children. I think I thought I was going to highlight that, but there's no role of CT chest in the children unless you need something for a child who's ventilated. Otherwise, no role of CT chest. That is again has come up
even before you start ventilation.
No. We don't say so. That is another thing very clearly come up in the guidelines. So no role of CT chest.
As we know, this is a post-COVID sequelae complication. Seen between toward second and sixth week. But again, you are saying RT-PCR, if it is positive, you say it could be missing. How to differentiate whether it is missing or acute COVID-19?
This is typically which happens for say someone who's presenting between the 2 to 4 weeks, the early one, or as well Dr. Farhan saying, someone who have a delayed viral clearance, where you have RT-PCR with the CT value say 30, 28. So they still not clear these things. So the way to differentiate between it is more of MIC or acute COVID illness is acute COVID illness have dominantly lung involvement. BC has more of cardiac involvement. Acute severe COVID has more for someone who has a previously comorbid condition. MIC happens someone who's already healthy and has some these things. BC has more of GI symptoms, and the CRP and inflammatory markers are significantly rated in BC compared to acute COVID. So these are some of the way you can differentiate between both. So there will be some segment where there will be little overlap, especially those who are presenting at the end of second week, third week, they will have some overlap with because I told you there were some cases in our series of 109 where both RT-PCR and antibody both came positive. Because the antibody response starts at the end of 1 week. So you will have both positive at this time.
The last question was came in the chat box, probably relevant in US and other places. How do you interpret it in those who are vaccinated? US, you have children between 1 to 18 who are vaccinated. So how do you interpret, because they would obviously have the antibodies post-vaccination?
See, I think that it's a type of the antibodies, the spike antibodies and other things which we have to look at. See, what we are getting now is generally given IgG antibody levels is what they give us. And most of us don't get differentiated. It's a spike level type of antibodies for type. And receptor antibody levels or another things which we say. So whether this antibodies is post-infection or this is vaccine related antibodies, how do we differentiate is what is sort of the question which they have. I think this antibodies following vaccinations do not cause missing. That is very clear. So the antibodies following this thing, they are not known to, because these are not immunological response which will dysregulated immunological response. So I don't think that we would be in that situation where you have COVID antibody positive and you have MSC like feature. So that should not be a problem. But when you are checking for antibodies, I would say always ask for the spike antibodies to know, whether they are getting protected or not. That's probably what I would say. But you should not have that problem because the antibody following vaccinations are not known to cause MSC.
But there will be a confusion when the child comes with fever and high inflammatory markers, and there was a vaccination given 1 month ago. Antibody will be positive, and antibody will be because of vaccine. So we don't know whether this is MISC or this is a dengue or this is. It will not be because of vaccine.
With the mRNA vaccine, there have been some case report of cardiac inflammation following mRNA vaccine.
Okay, sir.
So there have been some case reports. There have been nothing reported so far from Covaxin. We still are awaiting some data about Covaxin. But there have been some report following mRNA vaccine in US that there have been inflammation of the heart. So what happened to them, that data is not available, But there have been some reports about that following vaccination, there have been some inflammation of the heart. So whether whoever is asking in the chat box, they mean that, I'm not sure.
The more complicated
Over to you, Dr.
Yes. So, good afternoon, everybody. I thought we forgot to manage dengue in last 1 year. So, yes. So I thought we will have a small lecture on dengue also. So we brush up our knowledge about dengue, which is our old friend. So we know this is a flavivirus with 4 serotypes, 1, 2, 3, 4, and there was a 5th serotype which was discovered in Malaysia, not widely reported in India. And immune response also is very well known to all of us that the infection by one serotype gives lifelong immunity, but the protection is not provided to other serotypes. So you can still get infected with other 3 serotypes. So one person can practically get 4 times dengue infections, and the subsequent infection shows stronger and stronger immune response. And the important point in dengue is the 2nd and 3rd and 4th infections will have higher IgG response compared to IgM response. So in normal infections, we say IgG positive means old infection, but no, if you have an IgG positive dengue, it is possible that this patient may have got a dengue with another serotype last year, and this time there is another serotype which is causing an IgG response. This is important thing which we need to remember. And this is how the response happens. If there is a first infection, the primary response is IgM in 5th day, from 5th day onwards, and then from day 8, day 9, you can get an IgG response. But if you get a secondary infection, that means first year you got a first serotype and then you got infected with the second serotype, then IgG response starts earlier and IgM response follows a little later. And NS1 antigen is positive from day 2, day 3 itself in both the cases. So when it comes to diagnosis, virus isolation is of course gold standard. PCR is also very sensitive, but in our normal practice, we use PanBio, IgM, IgG, ELISA, and we use NS1 antigen, which are approved by the WHO. Rapid ELISA test is not approved by WHO. Similarly, NS1 antigen is a highly conserved glycoprotein, which is a test used again for diagnosis of dengue. Again, in NS1, there are 2 types. One is ELISA test and another is rapid test, rapid NS1. Again, rapid NS1 is a card test, which is not a very reliable test. So NS1 ELISA is something which is recommended or endorsed by the WHO. So how we do investigation, once your child comes with fever, with high-grade fever, and we suspect dengue, and if it is day 2 of fever, we send NS1. We may send an IgM from day 4, day 5 onwards. And after day 5 of illness, from day 6 onwards, there is no need to send NS1. You can send IgG, IgM. So this is how we plan our lab diagnosis. Now we know what happens to after we get exposed to dengue. There is a first infection usually goes asymptomatic, but it leads to reinfection. The second infection is usually stronger, and that leads to release of cytokines, particularly pro-inflammatory cytokines like IL-2, interferon gamma, and tumor necrosis factor alpha. And that leads to the main pathogenesis of dengue, which is capillary leak syndrome. So the tone of the capillaries is absolutely normal. So only there is a leaking of the plasma from the capillaries. So it is just like trauma patient, the trauma patient who's bleeding. So there is hypovolemia because of loss of volume of plasma into the third space. And this leads to intense spasm of the arterioles to maintain the blood pressure. This elevates the diastolic blood pressure. And because diastolic blood pressure is going up, there is a narrowing of the pulse pressure. And eventually, if there is too much loss of volume, then it will lead to fall in the systolic blood pressure, leading to hypotension. So this is what happens in dengue: leaking of plasma, narrowing of pulse pressure, coldness of extremities, followed by hypotension. And when the plasma is leaking, then naturally there will be hemoconcentration, so hematocrit will rise, coldness of extremities, and narrowing of pulse pressure and shock. Thrombocytopenia happens because of direct immune destruction of the platelets by the virus, or it can be because of bone marrow hypocellularity and platelet dysfunction. Now, how to differentiate between septic shock and dengue shock? Septic shock comes with vasoplasia most of the time. So we have wide pulse pressure. They require a lot of fluid boluses. So you will have rapid fluid boluses. You will require push-pull technique, 30-40 ml per kg within first 1 hour. And then you may require norepinephrine, epinephrine. So more requirement of inopressors. While dengue shock comes with cold extremities, narrow pulse pressure, if you give rapid boluses with push-pull technique, all the fluid will leak out and it will lead to more third spacing. So you have to give slow boluses as long as the blood pressures are normal. If the blood pressures are low, then of course you have to give push-pull technique, otherwise slow boluses. And because arteriolar tone is already very good and there is a very good spasm already going on and diastolic blood pressure is already high, you don't need vasopressors. That is the fundamental management in dengue. And if you give more of dopamine and epinephrine and non-epinephrine in dengue, it will worsen the situation. It will cause more spasm, more hypoxia to the peripheral tissue, leading to more lactic acidosis. So we need to be careful in giving inotropes and vasopressors in dengue. So usually you manage with fluid and very less inotropes are required for dengue. And now the third player has come in the market, which is MISC. So how do you differentiate? It usually happens after 2 to 4 weeks of previous COVID illness, but it is not as it looks like, because now every second person is having COVID infection. So it's not easy to find out the history of COVID illness. Now patient comes with shock, pulse pressure can be normal or wide. And the most important thing is get an echo done early. Bedside echo immediately, right in the emergency room or in the admission in the ICU. And if the IVC is congested, if the cardiac contractility is poor, more likely it is MISC. Because septic shock children can have myocardial dysfunction, but it will be mild cardiac dysfunction. It's very unlikely that a septic shock or a dengue shock will come with severe LV dysfunction. They usually come with mild or no cardiac dysfunction. So if there is a moderate to severe LV dysfunction, IVC congested, it is more likely to be MISC before you are even waiting for your inflammatory markers. And then of course you will have your labs coming back, CRP more than 60 milligrams per liter, or 60 milligrams per liter or 6 milligrams per deciliter, or high ferritin or pro-BNP levels. These are high inflammatory markers basically. In dengue, you will not have very high CRPs in most of the cases, but in septic shock again, your inflammatory markers can be high. And in MISC, why it is important to differentiate? In septic shock, we knew that a lot of fluid is required, a lot of inotropes are required. In dengue, slow IV fluid is required, less inotropes are required. And in MISC, because there is LV dysfunction, again, you can't give a lot of fluid boluses, you can't start a lot of inotropes, vasopressors, because that will increase the afterload on the left ventricle and lead to more problems. So you need to be judicious in fluid therapy as well as in your inotrope therapy. And coming to category 1 and 2 MISC, sometimes MISC category 1 and 2 can come with mild hypotension in the emergency room. You may require one small bolus, 10 ml per kg of saline, and they usually settle down. So that usually is not a problem. They usually don't require inotropes. And in category 2, you will have coronary dilatation. So it's very easy to differentiate and then you can manage. And in category 3, shock, dengue shock, MISC shock, the treatment is 10 mg per kg of pulse dose of methylprednisolone and IV IgG, which is not the case in dengue shock and septic shock. That's why it's very important to differentiate these 3 shocks right in the emergency room, because your entire line of management is going to totally different. In dengue, you have to give slow fluid boluses, no inotropes. Septic shock, lot of fluids, lot of inotropes. In MISC, judicious fluid, judicious inotropes, pulse steroids, and IV IgG. So that's the thing. Now coming to classification of dengue. Dengue, as per WHO class, is classified as dengue without warning and with warning signs, and severe dengue. Severe dengue can be because of shock, severe hemorrhage, and multi-organ dysfunction. As we know, warning signs are continuous severe abdominal pain, persistent vomiting, fluid accumulation in the form of ascites, effusion, mucosal bleeds, lethargy, restlessness, hepatomegaly, and laboratory parameters like rising hematocrit with rapid fall in the platelet counts. And we know the 3 phases of dengue fever. The febrile phase, which is in first 2-3 days, high fever. Then there is a phase of plasma leakage, which starts from day 3, last up to day 6, which can be without any warning sign or with warning sign, or it can be dengue, severe dengue. Severe dengue means it can be with shock or multi-organ dysfunction. And there will be recovery phase. So 90 to 95% patients will have recovery from day 6 onwards. Only 5% unfortunate patients will go into complications. Coming to management, at primary and secondary levels, it is very important to find out who is in normal dengue without warning sign, with warning sign, and who is severe dengue, and then manage appropriately, refer the patient appropriately. So severe dengue requires immediate emergency treatment. Dengue with warning sign needs treatment in the hospital, admit the patient, and without warning sign usually can be managed on OPD basis. So severe dengue, you have to train your OPD staff for practicing pediatricians. You need to take a class. You have to explain to them what are the warning signs and train the nurses. The nurses in the OPD who are measuring the weight of the child, height of the child, they should be given some 4 or 5 important questionnaires, and they should ask and screen the patients, ask for these warning signs, because now the epidemic is going on for next 2-3 months. So find out who are having symptoms of warning signs. If there are symptoms of warning signs, they should be fast tracked. If there is any severe dengue symptoms, cold extremities, drowsy child, not feeding well from last 24 hours or 12 hours, immediately they should be taken to emergency room. They should not be allowed to wait in the OPD. Otherwise, we have seen a lot of disasters happening, patients collapsing in the OPD, then attacking the doctors. Then the second is dengue with warning signs. So again, the OPD staff should be able to identify who is with warning signs, severe abdominal pain, poor oral intake, high grade fever, and they should be fast tracked in the OPD. They don't need to send in emergency room, but they should not be allowed to wait in the OPD for a long time. They should go to meet the doctor early, some doctor, and then treatment should be started as fast as possible. And then without warning sign, they may wait for a little longer in the OPD and then see the doctor. So triaging is very important so that we don't mess up in the OPD and create troubles. On OPD basis, we all know the management. Manage with paracetamol, avoid the NSAIDs, encourage oral feeds, and rapid sponging. That is important. Aspirin can be associated with Ray's syndrome, so avoid aspirin and ibuprofen and mefenamic acid. Instruct the caregivers that they should come back to emergency room or hospital if they see some signs of clinical deteriorations in the form of drowsiness, poor oral intake, severe abdominal pain, persistent vomiting, cold extremities, etc. You can actually give them this kind of some patient education leaflet so that medical legally also you are safe that you have educated them about what to look at home for warning signs. Now, what are the admission criteria? You admit them when there is a poor oral intake, high grade fever, altered sensorium, or a child who is less than 1 year with high grade fever, poor oral intake, always better to get admitted. Then shock, poor perfusion, oliguria, thrombocytopenia with spontaneous bleeding, and evidence of capillary leak in the form of ascites effusion. These are the admission criteria in the hospital, not necessarily in the ICU. Coming to management of warning signs, usually we don't start antibiotic for simple dengue without shock, just with warning signs. Obtain a reference hematocrit value. This is very important. So have a baseline hematocrit so that you can titrate your fluid therapy based upon the hematocrit in the future. Give only isotonic saline. If the child is less than 6 months of age, use half DNS. Start with 3 to 5 ml per kg initially, first 1 to 2 hours, and then look at the color, perfusion, coldness of the hands and feet, pulse, quality of pulse, and based upon that decide to reduce the IV fluids in subsequent few hours. Now, how to interpret hematocrit? The hematocrit which we get in the CVP report, usually it is little lesser than actual hematocrit which we get by Winthrop method. So in our hospital, we get PCV by Winthrop in addition to the PCV which we get in the CVP report, because it gives you more accurate information about your fluid therapy. So hematocrit can rise or fall, or patient can improve or deteriorate. There are 4 possibilities. Patient is improving, hematocrit is rising. Patient is improving, hematocrit is falling. Patient is not improving, hematocrit is rising. Patient is not improving, hematocrit is falling. These are the 4 options or possibilities in front of us. So if the patient is not improving and hematocrit is rising, that means there is ongoing capillary leaking. So you need to increase your fluid therapy, which can be increasing the saline infusion, or you may give some 5% albumin. Second possibility is patient is improving and hematocrit is rising. So you need to just wait. If the patient is clinically better, only hematocrit is rising, but sensorium is better, extremities are warm, pulses are good. Just wait for another 24 hours, things will settle down. The fluid which was there in the third compartment, third space, it will come back into intravascular compartment and the hematocrit will also start stabilizing. The third possibility is not improving and its hematocrit is falling. That means there must be most probably a GI bleed. And in these patients, these are sicker patients and they need blood transfusions, PRBC transfusions mainly. Then improving patient, warm extremities, good pulses, but hematocrit is falling. Again, a dangerous situation where the third spaced fluid is rapidly coming in the intravascular compartment, leading to fall in the hematocrit. So here we need to be very careful about IV fluids, reduce your IV fluids. You may even give Lasix, or you may have to consider dialysis if there is a lot of fluid overload. So when to transfer to a higher center? If a child has severe dengue, the child with shock or multi-organ dysfunction or bleeding, or child with warning sign who is less than 1 year of age or more than 12 to 14 years of age, and you don't have facilities to monitor the patient in the ICU, better to refer early rather than refer after deterioration. Early presentation with shock. Somebody coming with shock within 2 to 3 days of fever. Generally, we see shock after day 3. But if somebody is coming within 48 hours in shock, this is going to be a trouble. So better to shift the child to higher center if you don't have facility to manage. Severe plasma leakage, undetectable pulse and blood pressure, severe bleeding, fluid overload, we all know. These are the important things when we have to refer. Organ impairment, of course, if there is a hepatic failure, cardiomyopathy, encephalopathy, then we need to refer them. Now coming to management of severe dengue, again same saline we need to give, and hematocrit is very crucial. So the first time you get an IV cannula, get the blood sample for CVP hematocrit, that is PCV by Winthrop, and so that you can titrate your fluid and insert arterial line immediately when you are getting the pulse, because once the patient deteriorates, it's very difficult to get arterial line. Surprisingly, this is the part of 2009 WHO guideline also, getting an arterial line early. Usually WHO talks about management in villages and all that, but even they have mentioned that arterial line placement is so important in management of dengue early, because then you may not get it later and then it becomes a problem. Degree of intravascular volume deficit in dengue varies. Again, many times when we take rounds, the fellows or registrars will say child is in so much positive balance, but actually child is not in positive balance. You have given 2 liters, child has passed only 250 ml urine, but remaining all 1.5 liter fluid has gone into third space. And nothing is there in the intravascular compartment, and you need to still give some fluid to keep the intravascular volume floating. Otherwise, there will be lactic acidosis and so many other things. So you may apparently feel that the patient is in positive balance, but all the fluid is in the third space, and you still have to give extra fluid to maintain intravascular volume. That's the problem in dengue. So what do you do when the patient comes in shock? Shock means when the cold extremities with narrow pulse pressure, but compensated means systolic blood pressure is above fifth centile. So you insert an IV, you start normal saline or ringer lactate at 10 ml per kg. And as I said, in dengue, we always give slow IV. So we give over 1 hour, and then we assess at the end of 1 hour. If there is improvement, then start reducing this IV fluid to 5 to 7 ml per kg per hour, then 3 to 5, then 2 to 3. Slowly, every 2 hours, start reducing the IV fluids. If there is no improvement, then you again assess the patient clinically and hemodynamics wise and look at the hematocrit. If the hematocrit is decreasing or increasing, if the hematocrit is decreasing and patient is not improving, there is internal bleeding, give PRBC transfusion. There is a school of thought which says that you should give whole blood because that is going to provide plasma also. Dr. Suchitara Ranjit in Chennai, she believes in this. But PRBC transfusion is also sufficient. We give decreasing hematocrit. And then second possibility is not improving and rising hematocrit. So that means there's only leaking going on. And then you just give second bolus of normal saline or ringer lactate 10 to 20 ml per kg this time. And if the patient is still not improving, then you can give third bolus as 5% albumin. So first 2 you can give 10 and 10 ml and saline, and then third can be given as albumin. Now the other possibility is dengue coming with hypotensive shock. So when it is hypotensive shock, then you need to give first bolus only as a fast bolus, which will be 10 to 20 ml per kg saline. Or if there is a bad shock, you may have to give first bolus itself as a 5% albumin. But practically speaking, first bolus 5% albumin is usually not possible because the 5% albumin bottle is usually kept in the fridge and it will require some warming. So usually you will be giving saline as your first bolus, 5 ml to 10 to 15 ml per kg or 20 ml per kg. By that time, your 5% albumin will come and warm up. And then you assess after this. If there is improvement, then of course you will start reducing your fluid as we discussed before. If no improvement, you review your hematocrit. Low hematocrit, give PRBC transfusion. High hematocrit, repeat of bolus. Now second bolus, if you give first bolus as saline or ringer lactate, and if the blood pressures are still not improving or lactate is still high, second bolus can be 5% albumin. Now 5% albumin also leaks just like saline, but 5% albumin leaks slower than saline. So that's why 5% albumin can be given. Generally in 24 hours, we don't give more than 30 ml per kg of 5% albumin. Otherwise, all that albumin is bad actually. That will leak into the pleura causing more pleural effusion. It will leak into ascites causing more ascites. So generally we don't give more than 30 ml per kg. If it is an older child, adult, bigger child, we don't give more than 500 ml of albumin maximum 750 ml like that for in a day. What about colloid versus crystalloids? There is no clear advantage. As I said, colloid leaks slower than crystalloid, but it will also eventually leak. We don't use starch and gelatin because that is associated with DIC and renal injury. So what are our endpoints? Normalize your systolic blood pressure, get the pulse pressure higher than 30, and then it can be very temporary. You have pulse pressure of more than 30 for a few hours, and again pulse pressure can become less than 30, and then again you have to give fluid bolus. So this can go on, and you have to keep a very close watch. So there's no substitute to close monitoring. You have to stand there entire night and entire day, and you have to keep monitoring in that particular phase of 6 to 12 hours. That is very crucial. You need to stand there and manage. That's what I tell our fellows, that everybody has the recipe of making biryani, but tasty biryani only few people can make, and that is only hard work. So you need to, if you don't stand there, if you just take dengue guideline from WHO, it is not easy to manage. If you don't stand there, and if you are not monitoring the patients, then just starting IV fluids as per dengue protocol from the WHO will not save patients. Now, this is the one example. This patient was admitted 10-15 days ago. You can see very narrow pulse pressure, big child, around, I think this child was 14 years old, 70/60, hardly pulse pressure is 10. And because there is a severe hypotension, we decided to give him 5% albumin by push-pull technique. So this brother is giving albumin by push-pull technique. And you see how dramatically the blood pressure improved. 95/80 and 100/80. See, so immediately on the spot blood pressure is improving, but it is just temporary. After some time again it will leak. So there is no substitute to close monitoring at the bedside and keep watching the child very closely. So coming to refractory dengue, what is refractory dengue? You give 2-3 boluses of saline, 5% albumin. You started some inotrope if required. So as I said, there is hardly any role of inotrope in entire dengue WHO guideline. There is no inotrope, no norepinephrine, epinephrine, because there is no problem of vascular tone. So just manage with fluid therapy. And if there is a refractory shock, that is usually because of occult bleed or bacterial sepsis along with dengue. A lot of patients coming from Maharashtra area, we get scrub typhus also along with dengue. Malaria can happen with dengue. That can also lead to problems. Then dengue can have with myocarditis. Dengue can itself cause myocarditis, or the capillary leak which is happening everywhere can happen inside the myocardium, also leading to myocardial edema and cardiac dysfunction. Abdominal compartment syndrome, when there is a severe ascites and intra-abdominal hypertension, can lead to decreased venous return to the heart, and that itself can lead to persistence of shock and uncorrected metabolic abnormalities. Fluid overload is a problem, and all the 3 phases fluid overload can happen because of over-enthusiastic resistation, inappropriate fluid resistation, or in the last phase. Most of the times we get fluid overload in the last phase, where we fail to recognize that capillary leakage has stopped, and we continue to give fluid, and actually leakage has stopped and fluid is coming back from third phase, leading to fluid overload. So this is important. Now coming to the last part of my talk, that is complicated dengue. So we'll just go through quickly 2-3 scenarios. The complicated dengue can happen because of persistent leaking, because of some hematological complications like HLH, like picture in dengue, or neurological complications. So we'll see this first scenario. 7-year-old child comes in the emergency room with 5 days history of fever, hypotensive shock, low platelets, dengue, IgG, IgM, both are positive. Abdominal pain and vomiting is there from 2 days. NIBP is 88/65. Cold extremities up to ankles and wrist. Child is alert and anxious. Fluid management is followed as per WHO protocol, which we discussed. Everything was done. 12 hours after admission, child is still drowsy. There was no arterial line placed in this child. So non-invasive blood pressure was 75/45. Acidotic breathing, no urine from last 6 hours. There was abdominal distension suggesting ascites, and chest X-ray showing massive right-sided diffusion. Hemorrhagic angiospirate, and child had a big hematochezia. Severe metabolic acidosis, as you can see, with lactate of 12, hemoglobin of 8 grams, very severe thrombocytopenia, and SGPT of 10,000, and severe coagulopathy with INR of 4. So the problem here is the hematocrit was falling. There is metabolic acidosis, there is persistent shock. So most probably there is a GI bleed going on, and there is an abdominal distension ascites. So most probably there is an intra-abdominal hypertension also, and they have not recognized this problem, the treating team, and they did not even put arterial line. So this child was intubated and received multiple blood products, and intra-abdominal pressure was monitored. Abdominal pressure was 25. So there was abdominal compartment syndrome. SD catheter was placed, and later CRRT was also started. And in 12 hours, everything settled down and child improved. So first thing in complicated dengue management is use of bedside ultrasound, which is like a stethoscope. It starts right from an emergency room or right from entering PSU, and every half an hour, every 2 hours, it has to be used. It is used to assess the size of the cardiac chambers, contractility of the heart, caliber of the IVCs, IVC collapsibility index, and we can also do lung ultrasound to look at the possibility of lung edema or pulmonary edema. So what we see is this is a congested IVC, as we can see here, full congested IVC, hardly any collapse, and big dilated cardiac chambers. So this is all sign of fluid overload. So this can be detected by a bedside ultrasound. This is a chest ultrasound showing multiple B lines. So this is a sign of pulmonary edema. So this is very useful. Ultrasound is very, very useful to titrate the fluids. So if your registrar is saying that I'm positive by 1.5 liter, but my IVC is completely collapsed, heart is very small, I can still give some more fluid. And if the IVC is congested and heart is dilated, then I can restrict myself. Now coming to intra-abdominal hypertension, how to measure? It's very, very simple. Those units who are having intra-arterial pressure monitoring can easily monitor intra-abdominal pressure monitoring. How? There is a Foley's catheter here. Okay. This Foley's catheter can be connected to a 3-way. This 3-way is connected to 2 more 3-ways. Now this 3-way is connected to this urine bag. So normally this direction is like this. So urine is continuously draining like this to urine bag normally. Now when you want to measure intra-abdominal pressure, you just change the direction of this 3-way towards this. This part is connected to your transducer, pressure transducer, normal pressure transducer, which we are using for arterial pressure monitoring. Simple. And what you do, whenever you want to check the intra-abdominal pressure, just change the direction on this side, push some saline inside. How much? Usually we push around 10 ml per kg. If the child is big, around 30 to 40 ml, not more than that. And then zero it and measure the pressure. Normal pressure is 0 to 5. If it is more than 12, we say it is intra-abdominal hypertension. If it is more than 20, then it is intra-abdominal compartment syndrome. And if lactate is high and shock is not resolving and pressures are more than 15, 16, 17, it's always better to insert an intra-abdominal PD catheter or something and drain the ascitic fluid to reduce the intra-abdominal compartment syndrome, and patient dramatically improves. So see, this is the direction is changed. And then just take some saline. Push it in the bladder. If it is a big child, we give maximum 30 to 40 ml and then measure it. Here we can see it's around 10. The pressure is shown as 10. So it's not that difficult. Anywhere where arterial pressure is monitored, this can be monitored. Another scenario is 11-year-old boy with 5 days history of fever, abdominal pain, vomiting, admitted in referral hospital. 2 liters of fluid was given there. When the child arrived, the child's blood pressure was okay. Peripheral pulses were weak, abdominal distension with hepatomegaly, chest showing bilateral effusion, moderate ascites, gallbladder wall edema, 2D echo showing good biventricular function. And this child's SGPT was 8,000. Serum ferritin was 47,425. So child had a severe dengue shock with acute liver failure, severe hyperferritinemia, and multi-organ dysfunction. So fluid management, invasive hemodynamic monitoring, all those things which we discussed was started for this child. Blood products were given. And for multi-organ dysfunction, methylprednisolone was also started because of possibility of HLH after doing a bone marrow. And because of hyperlactatemia, hyperferritinemia, and MODS, CVV-SDF, that is CRRT, was started in this child. 5 cycles of CRRT were given 8.3 liters fluid was removed in 5 days. Metabolic parameters optimized. This is the patient. And this is the CRRT, this is the same child on CRRT. And 4 days of hospitalization, such a sick child would have obviously died if we would have just left him. And his metabolic acidosis improved, LFT lactate improved, and he went home. So what is the role of CRRT in sepsis? It helps us management of fluid overload, first of all. Second thing is management of azotemia, correction of hyperlactatemia, hyperbilirubinemia. Within first few hours, CRRT also helps as an adsorbent. So it removes the cytokines. It improves the coagulation response. We have seen the coagulopathy improves. Although people say that CRRT can cause coagulopathy, but if a patient is already in septic shock or dengue shock with DIC, as the cytokines are removed, pro-inflammatory cytokines, the CRRT improves the DIC. So what is our experience? In last 5 years, we have done CRRT in 95% patients, and out of which 41% were dengue with MOTS who received CRRT. And this was our survival in these CRRT patients. And most of them, all those who died actually had significantly high SOFA and PRISM scores. And as you can see, early CRRT had better survival. And we had seen that those patients where CRRT was started within 12 hours of admission, who were sick, of course, had significantly less ventilator days, PSU days, and hospital stay. So early CRRT is so important. If the patients are referred at right time and you start CRRT early in first 12 hours of arrival, their ventilator days, PSU stay, hospital stay, and mortality is much better compared to late CRRTs. Now coming to home adsorption, this is a 12-year-old girl who comes with 6 days history of fever, and abdominal pain, drowsiness, decreased activity. PCT is 4.4, thrombocytopenia, leukocytosis, and she was intubated immediately and ventilated, requiring very high ventilatory pressures. Her peak pressures were 32 centimeters of water. IVC was congested. Arterial lactate was 12. Urine output was falling. She was started on CRRT also within 6 to 8 hours of admission. So she came at around 7 p.m. and by 10 p.m. we started a CRRT also. But the acidosis was still persisting. Next day morning, we saw the acidosis still going on. Ferritin was 77,400. INR was 4.2. Lactate came down from in CRRT, but urine output was still bad. We calculated the cytosop score. It was 12. So we started this challenge cytosop. Cytosop is an extra filter. It's an adsorbent filter which is attached as parallel with the CRRT filter. And this is how cytosop works along with the CRRT. So it basically is an adsorbing surface which adsorbs the pro-inflammatory or anti-inflammatory cytokines from the body. And this child was obviously in cytokine storm because of ferritin of 47,000. So as we can see, CRRT was provided for 5 days, 2 cycles of cytosop was given. So here cytosop was given for 2 days, and we see dramatic improvement in INRs and dramatic fall in the ferritins, improvement in the PCT, urine output started improving, everything started improving. Such a sick child who came with a ferritin of 47,000, intubated in emergency room, got extubated on day 5, CRRT stopped on day 6 and discharged on day 10. So very, very quick dramatic response to, so that is how, the beauty of starting CRRT cytosop early cuts down your ventilator days, lengthen the ICU also. So these are the types of filters which can be used for adsorption, oxidase, toramycin, cytosop. And lastly, neurological manifestation. This is the most devastating thing which we all see, and this comes in cycles. So every 2-3 years, we see more neurological complications of dengue, and then it goes away. Then again, we see, and we still don't know what is the reason, whether it is direct viral invasion or autoimmune phenomena or encephalopathy. Most of them we see, just like Japanese encephalitis, there is a hypodensity in the basal ganglia area, and very short history. The child will have fever, and then within hours, child will have seizures and go in coma, and within hours get intubated and die in front of us. Management is largely supportive. Management of shock, bleeding, dyslipidemia, pulse methylprednisolone we have tried. We have tried the tocilizumab also, but we still don't know how to manage this acute necrotizing encephalitis of dengue. It's very devastating. So the only way we can prevent is by low index of suspicion, low threshold for steroids, and maybe there may be some role of cytosorb or something. So to summarize, complicated dengue carries mortality and morbidity. and outcome depends upon early identification and complications, close monitoring of clinical lab parameters, availability of advanced monitoring facilities. Advanced modalities like CRRT, hemabsorptions have shown promising results, provided they are used in the early course of the disease. Experienced team of doctors and nurses, nursing care is very important, because all these dengue patients, they come with dengue, and if there is no good infection control, if there is no other good infrastructure, then they may carry secondary infections and they may die because of sepsis, ventilator-associated pneumonia, catheter-related bloodstream infections, and other things. So that also is a very important part of management of these sick patients. Thank you.
More than 12 to 14 years. What is so special about this for 12 to 14 years?
High risk.
Why they are at
Obese, particularly obese children.
I should say that, I mean, you want to say that more obese children.
And older children also. And then older children are also.
Understand less than 1 year, but now you're saying more than
12, more than 12 to 14 years of children with warning signs.
With warning signs.
No, yeah, not all dengue patients more than 12 to 14 years.
Okay.
Children.
Is ferritin a criteria for transfer?
Sorry?
Ferritin levels?
No.
This would not be a criteria. In your cytosol, you said ferritin is a criteria for levels is a criteria.
Ferritin is a non-specific marker. If the patient is clinically stable, you don't react to ferritin. If the patient is clinically unstable, high-grade fever, requiring multiple inotropes, shock, and ferritin is also high, then you react to it.
Okay.
If the ferritin is, sometimes if the ferritin is 70, 80,000, but if the patient is clinically improving, if the blood pressures are like the patient which Earjun sir has referred, in that child we did not start cytosol. Second day, because ferritin was very high in that child, sir. I think it was 30, 40,000 something, but we did not start cytosol because patients started, the inotropic requirement started coming down within 24 hours. When we started CRRT. Sorry, sir?
You won't go by the cytokine level.
We did IL-6 level also. IL-6 level was 256, sir. So IL-6 was 256, ferritin was 20, 30,000. It was very classical cytosol requirement, but we started CRRT, and with CRRT child stabilized. So when the child started stabilizing in 12 to 24 hours, we decided no need of cytosol.
You said that
so it all depends upon how the patient is responding. If suppose this patient would have continued on 2-3 inotropes on day 2, fever is still going on, and second day again ferritin is rising more, IL-6 is rising more, then we will have started cytosol.
Yeah, now you said that inotropes don't have much of a role, but many of them are shocked that they are having myocardial dysfunction.
Yes, in that case, then we have to. I'm saying normal dengue, when the patient comes in shock, when first entry, then, but if the patient is going into refractory shock, then you have to start inotropes.
Thanks.
Thank you. Farhan, if you could just go through the chat box and take up questions that come up. Request everyone to please post their questions in the chat box. You can start with Dr. Sunita's question. Yeah.
Any role of FFP instead of albumin? See, some people use FFP as a bolus. FFP as a bolus can cause trally. FFP as a bolus can cause hypotension. So FFP should not be used as a bolus, as a substitute to 5% albumin, ideally. Sir? In a very bad bleeding from everywhere, patient is bleeding. Sir, see, factor 7 you have to use along with cryoprecipitate, sir. Many people don't do that. If you don't provide a substrate and give only factor 7, it will not work. So you have to give cryo and after that give factor 7. It helps, but again, you have to manage the other causes of DAC. So we have used for 3-4 patients, but you have to manage other cases, other causes also. You need to give cryoprecipitate, then give factor 7. Yes, provide a substrate and then give.
Farhan, there's some questions. You can scroll up.
Yes, sir.
So that we don't miss out. Yeah. Dr. Sunita, after what time bolus? Just go up.
Can you please elaborate?
Don't go down. Up. Yeah.
After what time should the SCT be repeated? 6 to See, again, SCT depends upon how sick the patient is. If it is mild dengue, there is no need to do SCT. If there is a dengue with warning sign, you do SCT 12 hourly is fine. If there is a dengue with shock, compensated shock, you do SCT every 6 hours.
Extension, is there a value for us to be scared in the OP setting?
More than 40, 42, you should be scared.
Is it age dependent? Because many of them we are seeing now around 44, 48, but I mean, at least 42, 44s, but they get better after the third, fourth.
Yeah. Many, you don't need to admit them. But if they are sick looking, if they are having poor oral intake with 42, 44, better to admit. If they are having poor oral intake, but the HCT is 34, 35, you can wait. That's how you can decide.
So in a typical practitioners or a OP setting, which child is the one who needs to go to the hospital on the third, fourth day? Because we do expect the fever to stay on the first 48 hours.
Yes.
So do we depend on this hematocrit, or do we still go back to
Clinically? Clinical plus hematocrit can help in the sense, if the hematocrit is suppose 52, then definitely you'll think about admission on OPD basis also. Big children particularly, 12, 14-year-old child, poor oral intake, it is very difficult to assess them because they will be talking to you. They will appear very normal to you. They will be sitting in front of you, they will be talking to you, they will not look very sick. So if you send us a PCV, we had one patient 2 weeks ago. I had to admit them because PCV was 52 PCV, but he's normally talking, very old patient of mine. There was nothing to suspect, but oral mother is only saying that he's not eating, and mothers always say child is not eating. So I just got CBP PCV is 52, admitted luckily, and then we saw platelets rapidly falling. 2-3 days platelets kept on falling.
Of the leukopenia, because we're seeing 2000 nowadays.
2000, 2500, and then they will start rising. Leukopenia will be there, but you are saying how to decide.
For an admission or a referral?
No.
Leukopenia. Yeah, so because the parents, once they see the report, that bold, it strikes out. In fact, they don't look at hematocrit and it doesn't come bold. Actually, if you see most of the labs, they give up to 50 hematocrit. So even if I try to explain to them it's 44, you may have to be careful. They listen to me only looking at the platelets. Platelets 1.3, their mind is set only on that.
Yes.
So is there any such, let's say, target for both WBC count and platelets that we need to
WBC count is going to fall, we all know. Platelets, you need to see how quickly they are falling. If they are falling by 10,000, 20,000 per day, you can wait. If you did CBP today and you did tomorrow, and the platelets have fallen by 50,000 in a day, better to admit, because they have fallen rapidly in a day. So it's better to admit and observe in the hospital.
Yeah, we'll go back.
What do you say, sir?
Some more questions have come out.
Yes, thanks.
Go back, Farhan, so that we cover the questions.
Sir. NS, sir. NS or ring-elected, both are same. NS is fine, sir. Yes, sir. I think recently a study was done, no? Anupama? NS versus ring-elected has shown that both are same.
So can we give alternate?
Why?
Like one fluid NS, one fluid ring-elected. Both are fluid echo. Which patient?
Anybody requiring boluses? Anybody whose extremities are cold, sir, and whose pulse pressures are narrow, you do a echo and find out what is the baseline IVC and cardiac chamber size, and then keep monitoring. Not by cardiologists. Cardiologists, 2D echo is different, and the 2D echo which we do for assessing fluid is different. Yes, sir. Concept of actual fluid balance. Any role of IV IgG and steroids in dengue? There is one question on role of IV IgG and steroids in dengue. So immediately in acute dengue, there is no role of IV IgG and steroids. Particularly in first 4 or 5 days when there is a viremia, steroids can be dangerous because they can propagate viremia. Just like in COVID also, we say there is no role of steroids in first 5-6 days. But if the patient has gone into HLS-like situation, after dengue, we have seen some children, they go into they recover, from shock, and then again develop a secondary fever from day 7, day 8, day 9. They develop a new fever, and then again their ferritin starts rising, or they develop some transaminitis and persistent fever. Again, platelets may start falling. So at that time, you may have to consider possibility of secondary HLH. So in that case, it is better to check the smear for possibility of malignancy, because we had 2 patients who came with dengue and subsequently developed acute myeloblastic leukemia. So, and 1 patient had developed aplastic anemia post dengue. So we can't just give steroids for everybody. We need to ask the pathologist to look at the smear, tell us whether it blast or anything. If you have any doubt, better to go for a bone marrow aspiration biopsy. After that, 1 mg per kg methylprednisolone can be given. In that case, you may even try for IVIG, but better to take consultation with the hematologist and do these things, because you should not miss lymphoma, leukemia, aplastic anemia, which can happen post dengue, or which may be there and dengue may be there on the top of it. Because if I say yes, you can try, then that's a problem. Then in dengue, everybody will start using steroids.
More
Sir.
questions, Farhan? The
Can you please
common
elaborate?
question
Yes, sir.
on NS1, and we're facing this wherein clear leukopenia, clear thrombocytopenia,
Where is it?
antibodies negative, NS1 on day 3 also negative. So what next? Do we
There can be dengue-like illnesses also. There are other arthropod-borne viruses.
So do you suggest we do chikungunya profile, or what do we do
After
next?
day 5. So those cases, you can have dengue IgG positive, but IgM will be negative. There will be cross reactivity. So there will be cross reactive seropositivity of dengue, but IgM will not be positive. So if you have a doubt like that, after 5 days you repeat IgG, IgM. If IgM is negative and only IgG is positive, then it is not dengue. Most probably it is a dengue-like illness, just like yellow fever or something.
And also safe in the OP practice to say that it's viral fever,
Viral
probably
fever.
dengue. The
Yeah.
treatment stays symptomatic.
Yes.
Yeah, that's the reason. In fact, one of them did it again through another lab, and then it came out positive. So I'm in fact, I
Again,
was
lab
safe
reliability.
that-
Lab
So I
reliability.
was safe saying that it's viral fever, query dengue,
Yes.
managed symptomatically. It's very important for
Or
us to
dengue-like
keep that.
illness. Yeah.
Yeah.
Yes. Role of Lasix in dengue, yes, on the last phase, after day 6, day 7, if there is a evidence of fluid overload, if there is a pulmonary congestion, severe ascites, something, then you may give, but avoid Lasix otherwise. Infusion, Lasix infusion, usually 0.3 to 0.6 milligram per kg per hour. Indication of albumin in dengue. Albumin in dengue, 5% albumin. We don't give 20% albumin in dengue generally. So 5% albumin is given as a bolus in shock with hypotension after first or second saline bolus has not worked. Then usually it will be a second or third bolus. And I said you don't give more than 30 ml per kg in first day, because all that albumin will otherwise leak and it will drag the fluid more into the third space. Same problem with 20% albumin. 20% albumin will do it even more. So you don't give 20% albumin for correction of hypoalbuminemia in dengue. So in dengue, albumin also falls in severe dengue. So when it is falling, you don't give 20% albumin. You keep watching that albumin, keep watching. So if it is 2.8, 2.6, 2.4, 2.3, don't give. Then 2.3, then again 2.3. Now it has plateaued off. And now the patient is still edematous. You want to give 20% albumin, then you give. Because now leakage has stopped. So it was 2.8, 2.6, 2.3, 2.3 for 2 days. You give 20% albumin, it will not leak away. And it will, then you give Lasix along with that, it will take the fluid out rather than leaking into third space.
Why there was no dengue last year? There was no epidemic like this year. Last year, why it was not there?
Really surprising. No? Punishment of God.
So I think I'll ask Dr. Anupama to take up the COVID plus minus dengue part. Last question, Dr. Karan. Anupama madam, chairs arrangements of such. Last question, what's the OP management you're following here? Yes, please go ahead.
Sorry. Yes. See, acute necrotic encephalitis is so dramatic. So dramatic. Within hours, it's very difficult to do anything. What will you do? The mothers have told us, child had fever in the morning. She gave some paracetamol, sent the child to school, and then child in the school had a seizure and came back in coma. क्या करोगे? हाँ. So after that seizure, only better to call. How will you know it is febrile seizure or other thing? It's not possible. It can be meningitis. It can be anything.
Screen share change. Sir, zoom up, YouTube. You'll have to reorganize.
Mask
So we all have seen COVID season 1, COVID season 2, and I don't think, or we might not see COVID season 3, but dengue is definitely come back. Our esteemed panelists today need no introduction. With their vast experience and knowledge, they would give their pearls of wisdom we'll be sharing about few clinical case scenarios about how to approach a febrile child during dengue outbreak in the middle of COVID-19 pandemic. So we have today for panel discussion, Dr. Dinesh Kumar Chilla, the Director of Neonatology and Pediatric Intensive Care, Rainbow Children's Hospital, Dr. Farhan Sheikh, Head of Pediatric Intensive Care, Rainbow Children's Hospital, Banjara Hills, Dr. E. Arjun, Director and Chief Pediatrician, Apurva Hospital, Dr. Sichitra, Associate Professor of Pediatrics, Gandhi Hospital, and Dr. Kapil, Consultant Pediatric Intensivist Neonatologist, Rainbow Children's Hospital, and myself, Dr. Ali. So we all know that WHO has declared COVID-19 as a pandemic in March 11, 2020. Dengue is endemic and has always been a major public health problem for us. If you look at the WHO website, for the last 10 years, the overall incidence of dengue has raised by 110 million cases. And now in Southeast Asian countries and in India, co-infection and co-occurrence of dengue has become a significant burden on our healthcare. If you see both dengue and COVID-19, they have some similar pathophysiology. Both of them stimulate the immune system. They activate pro-inflammatory cytokines, especially IL-6, TNF-alpha. In dengue, what happens is there's plasma leakage, there's thrombocytopenia, bone marrow suppression, and coagulopathy. In COVID-19, it goes and attacks the endothelial cells and causes endotheliopathy, and that causes thrombocytopenia, a syndrome of macrophage activation syndrome. It predisposes to venous thrombosis. So they have some similarities in their pathophysiology. So we all know that medicine is a science of uncertainty and an art of probability. This is what we feel whenever we see children in the ward, in the outpatient, or when we are seeing them in the ICU setting, or when we are seeing them in the emergency room. Whenever we see a febrile child, we are lost between this. Are we dealing with dengue, MISC, viral co-infections? Is this some other infection like rickettsial or a bacterial sepsis? So we'll go through a few clinical case scenarios, and then our esteemed panelists will give us their pearls of wisdom about how to manage or how to approach these children. So we had a 7-month-old baby. This was a doctor's child. This child was brought to the OPD with history of fever for 4 days. He was irritable, and the parents were anxious because his oral intake was poor. This child had history of COVID at 3 months back, and the whole family had a COVID exposure. On examination, he was slightly tachycardic but febrile. Temperature was 103. His CFT was mildly prolonged, and his blood pressures were fine and mildly tachypneic, and there were signs of dehydration. When a head-to-toe examination was done, his ears and throat were normal, chest was clear, and there was no obvious rash of mucocutaneous symptom, mucocutaneous involvement of the conjunctiva. There was nothing obvious. Blood workup was planned. Since the doctor had insisted on parental anxiety and poor oral intake, the child was hospitalized. And these were the initial labs. Child had a hemoglobin of 11, CRP of 10, and subsequently child's dengue NS1 antigen has come reactive, and COVID antibodies also have come reactive. So, Arjun sir, is this dengue fever or post-COVID febrile inflammatory fever? And this COVID antibodies was not sent by me, but the resident felt that we have to send, so she has sent COVID antibodies in these children. So all febrile children, when we see in our outpatient, do we need to send COVID antibodies?
Yeah, first of all, thank you for the opportunity. As you rightly put the slide where COVID and dengue both overlapping, and we've seen a fatality in our own medical community where they thought it is to be COVID, and then she suffered from dengue, and the dengue led to the complication. So we have to be always vigilant to the old illnesses than the current illness. Trying to overlap everything, put everything on the current pandemic. So as you rightly said, the age and then and the sudden onset of fever, no rash, no mucocutaneous, and with the leukopenia, we have to consider dengue only as the first possibility than COVID. And my experience, COVID has been very kind with children. Will continue to be kind with children, I feel so. Except that risk thing, which is a very less than 1% component. Dengue should be a strong possibility and probability. Of course, the COVID reactive antibody doesn't mean anything. And so we have to have a follow-up of this child because it's the first time. In my experience, I said that 2 peaks, 7 months to 9 months, and then 7 years to 9 years. So this first peak can be very disastrous at times if you have severe inflammation. So the dengue should be a high possibility, and also if since he's a doctor's child, he can very well take care at home and keep monitoring the child, both hematocrit as well as the platelet count.
As rightly said, not all febrile children we need to send COVID antibodies, but do consider when the child has got unexplained fever or mucocutaneous symptoms or there's lab evidence of hyperinflammation, especially in the outpatient setting when you see these febrile children. So this child, this is one of the recent.
Small thing. There was a child exactly same 8 months or so, belonging to a doctor from UK. The child was lost to dengue-related complications, the early phase of the pandemic epidemic about 12 years back, when we were all not so vigilant about dengue and dengue-related complications. It was really bad case which I heard from Krishna Children's Hospital. Child had MODS because of dengue. So we cannot just brush aside and then treat it as a just outpatient basis. Thank you.
So, recently, the study was published by AIMS, and they found out in 4 states, almost around 5,000 children they have analyzed, and they found out the zero prevalence of COVID antibodies is as high as 60% in children, and it is almost as compared as same as the adults. This child, because of anxiety, parental anxiety and dehydration, we did hospitalize, child stabilized, supportive care, discharge on day 3, and at the point of discharge, he started dropping his platelet counts, but subsequently in the outpatient follow-up, his platelet counts had improved. So let's go to the next clinical case scenario 2. 8-year-old girl, this girl had a background of chromosomal disorder. She presented with fever for 3 days, poor oral intake and vomiting for 2 days. Initially, the child was taken to the nearby hospital. Mother herself is a doctor because she felt that the peripheries, school peripheries were there, and child was in compensated shock. So they gave a small bolus at 10 ml per kg, and child was referred to a center. So at admission, child's heart rate was around 130. She was respiratory rate around 20. Blood pressures were fine. With the bolus, she settled down. Her peripheral pulses were well felt, but she was febrile, and CFT was less than 3 seconds. And when you do the head-to-toe examination, nothing obvious and no obvious rash or conjunctival redness. So the child was started on maintenance fluids and IV ceftriaxone after sending blood cultures, and the child was shifted to ward. So these were initial labs for her at admission. Her CRP was around 70. Cultures have been sent. So maintenance fluids, supportive care, and IV antibiotic was started. Subsequently, the next day in the rounds, the child continued to have very high-grade fever with poor oral intake. But otherwise, she was stable hemodynamically. Examination did not really reveal anything. So and then the labs were repeated. And when the labs were repeated, her CRP had jumped from 70 to 220. There was slight leukopenia compared to the admission lab, and platelet counts were normal. And this child both came positive. Dengue NS1 antigen came positive, and COVID antibodies had come reactive. Seeing that propelled us to do a 2D echo, and the 2D echo also was normal. So many times children with high-grade fever come with poor perfusion. You give them a small volume bolus, they settle down. So many of us are facing these children when they come to our emergency room or in outpatient. So at the first instance, Suchitra ma'am, do you think we should administer steroids in these children? Should we consider administering steroids at the first instance for these children?
One is what we have seen, adopted a thank Rainbow team as well as IAPTCB. Yes, nowadays what we are seeing the same scenarios. Based on the clinical history, what we have to see, fever of 3 days and more. And second thing that you have mentioned here, that the child was chronic shock. Acute febrile illness with shock within 3 days. I just don't want to start up a steroid immediately. Unless there is a clear-cut evidence or history of COVID infection previously or exposure to COVID. And if we suspect that it is a case of MIS. Because here there is the 2 things are react like dengue and COVID. Both are there. Which one is dominant? Predominantly, which one is there? So when 2 are there, it can nullify also. But here it is like we treat it whatever the management what you have said now. IV fluid bolus shock has been corrected, and we started with ceftriaxone to have a symptomatic treatment. So steroids immediately will not have any role.
So you would wait and see how the child.
Yes, we would like to see how the child is improved.
Since CRP is high, we should better do further second line of investigation.
Yes.
DDML, ferritin, and
Yes. So this child, the second line of investigations were done, and the inflammatory markers, I have not put it on slide, they were elevated. Echo was done, it was normal. So since the child fitted into the criteria of MISC, IV immunoglobulin and steroids were administered. Fever dramatically improved over 48 to 72 hours, and the child was discharged after 4 days of hospitalization and steroids with a tapering plan and aspirin. Again, within 2 days, the mother had to bring back the child to the outpatient with the complaints of poor feeding, vomitings again, and some dehydration. And on examination, child was normal. Because of the poor feeding and dehydration, the child had to be hospitalized. So when the labs were repeated for this child, what was noticed is the child had some amount of hepatitis. The SGOT, SGPT had risen up, and platelets were started going down in the downward direction, and the CRP has come down. So, Dinesh sir, how should we approach this? Does the child have MISC, or does this child now the dengue is the reason, or what should we do when we face such situations in this scenario?
So it's interesting. So the parents which and see in the first case, first situation, the shock was managed outside. One dose of steroid was given, and that's what I was trying to convey, that we have to start looking at not steroids just like that, without actually, as I said by Suchitra, without actually knowing how high is it. Is it MISC? So I really stopped the steroids and said we should not use steroids and we should think what it is, and that's how I stopped everything and like what we do. And then let us look at what is the cost for it. And then the test fever started spiking very high, 103, 104, CRP spiked 100, but no obvious cause was coming. And so a child who had cardiac dysfunction, presenting features of shock, very increasing CRP, COVID antibodies getting positive, and was getting sicker. It was getting this thing. So that is when sort of, and very dramatic improvement the minute you gave, the child got better. Whereas if you look at the second description, they had transaminitis, and that's probably whether aspirin steroid was causing gastritis, and that is the reason why the child was vomiting, or whether the transaminitis per se was causing did not. So we did not give anything to this child, just sort of give some hydration and settle down. And this drop in platelet, I think this time the dengue was acting, it is what we thought. And we just gave for 24 hours, I settled down and went home. So I think sometimes this is very, very tricky. I think it's all going to be learning for all of us. I don't think anyone is the master at this stage to recommend one or other. We have to balance on what is the situation which is prevalent at the time and take decisions. But I think when we are saying MIC, you need to have all the 5 criteria which the WHO or CDC has recommended before jumping on. To understand that the child gets the best treatment. And so you will have combination. The other thing which is the thing which now coming is about distributed response to dengue itself for patients who have been already exposed to COVID. So this may not be actually MIC at all. This may not be MIC at all. This says that you had been exposed to COVID and you had some immune sort of stimulation. And now when you had dengue this time, who had a dysregulated immune response or contracted dengue illnesses, and that is why this child presented like this. And this is what probably a lot of us might be saying, which is a contracted disease. This may not go through usual 5 days, 6 days, and then that dengue might start showing early these things because your immune system has been stimulated quite early exposure to them. So this is something which we probably hear a little bit more often from all immunologists over the next sort of month or so. But I think this is what we all are seeing. But treatment, probably you will have to vary based on what you're looking at. The high inflammatory markers, clinically sort of presence of the organ involvement probably prompt you to do what is best for this.
First instance, the child had very high CRP, poor oral intake, and some of the criteria fitted into MISC, though the echo was normal. And so that predisposed us to start the steroids for the child.
Again, that's why I stressed in my lecture. Echo is abnormal only in one series it was 60%, in one series it was 60%. So echo is not the criteria for the starting. This child had started having some GI symptoms. He had some GI symptoms, inflammatory markers, COVID antibodies. So that itself fitted into MISC. So on that criteria, he qualified. The only issue is there's a lot of controversy. Should we just give IVIG and leave it? Should we give IVIG and steroids also? So some people label steroids in the second line instead of giving IVIG and steroids. So that's always a controversy. So people would prefer to give IVIG and steroids, saying that the shock resolves faster, need for ICU stay is less, mortality is less. This is sort of mortality as such is not that very high. There has been the studies for this, but I think there has been a lot of controversy raised from Indian subcontinent about the cost of IVIG. And there's a study which is going to be done about actually instead of giving IVIG as the first line, why not give steroid at the first line? Because the cost of steroid is so less compared to IVIG. So you might see some actual evidence coming up saying, don't give IVIG, just give steroid, because this all has come up from the Western countries.
There is a Swiss-made trial actually which has started in April in Switzerland, which is comparing steroid versus IVIG. Sir, what I was saying is in MISC there are three categories. The MISC with shock, the one with proper shock, which requires 2-3 boluses and proper shock, will always have a left ventricular dysfunction. It is not possible to have a MISC category 3 with normal LV functions. Have a category 1, category 2 can have mild hypotension, which is settled down with 1 or 2 boluses of shock. That we don't call shock. They have defined shock also. WHO and CDC, AHA, they have defined shock. Shock means more than requirement of 40 ml per kg bolus or at least 1 inotrope to maintain the systolic blood pressure above 6 centi. That is the definition of shock. So if you require only 1 bolus in the emergency room and you settle down, that is not shock actually. So that's only a transient hypotension in category 1 or category 2. You don't need steroids there, and if you want to use steroid, 1 mg per kg if you want to.
So let's go to the third clinical case scenario. So this is an 8-year-old boy. He presented with high-grade fever for 4 days, poor oral intake for 1 day, and decreased urine output for 1 day. At presentation, he was in shock. He was tachycardic, 170. Blood pressures he was in the hypotensive range, had a wide pulse pressure. He was tachypneic also with a respiratory rate of 40. He was quite febrile, and he had bounding pulses, and liver was 3 centimeters below the right coast margin, and bilateral air entry was equal. So this child was stabilized with 20 ml per kg saline bolus, was started on noradrenaline, and a blood gas at admission showed metabolic acidosis with a lactate of 3. Subsequent labs have been sent, and in the labs, what was quite evident for CRP was very high, 235. Platelet count was 2.49 lakhs, and organ function, creat and SGOT, SGPT were not that significant. Normally in 2000, before 2020, before the COVID era, this is what we would do whenever we see a shock child in the emergency room. We resuscitate with fluids. We start inotropes if the shock is refractory to fluids. We give antibiotics after culture. Then we consider steroids, which is fluid refractory catecholamine resistant shock. But now with introduction of COVID into this picture, what should our approach be when we see a febrile child with high inflammatory markers and shock who is requiring around 20 to 40 ml per kg fluid bolus as well as an inotrope? I will ask Dr. Kapil to comment on this.
Yeah, as you said rightly, this child presented with shock. They presented in 2019, 2 years back or 1.5 years back before the pandemic era. We definitely treat as a septic shock or any infection related shock or any other reason for shock like shock, because we did not have MISC or COVID in that time. But the basic management of shock would be similar in the resuscitation, as we said, inotropes, antibiotics, unless we prove it's not septic and MISC. But considering not what we nowadays, what we see more of MICs, with this child boy presenting with shock, high inflammatory markers, definitely it's good to entertain the possibility of MIC and go for the further investigations, which we call tier 3 investigations here, to look for the cardiac involvement, to look for the other inflammatory markers on the ECG, echo, the D-dimers, which will help us establish the diagnosis, manage your treatment, decide about IVIG, steroids, and aspirin. So we would entertain the possibility of MIC here.
So we do a tier 1 test, and if a CRP is more than 50 or your ESR is high, or at least you have one of the following: lymphopenia, thrombocytopenia, hypoalbuminemia, sodium less than 135, or neutrophilia. This is the guidelines given by Ministry of Health and Family Welfare, as well as ACR also recommends the same. Consider doing tier 2 investigations, especially in the current scenario where MIC could be one of the strong differential diagnoses. So for this child, the tier 2 tests have been done, and the TROPI was elevated, and NT-proBNP was also significantly high. 2D echo showed severe LV dysfunction, showed moderate LV dysfunction. The coronaries were fine. COVID antibodies were reactive, and other infectious causes were ruled out. So what are the treatment options here, Farhan?
So in this particular case, you're saying, or
yes,
generally?
In this particular case, and as such, when we see febrile children with shock.
So in MISC, when you have category 1, child comes with only fever, raised inflammatory markers, and history of COVID contact or COVID antibody positive, and the child is otherwise able to start in his right. Don't start with steroids. Wait and watch. Repeat inflammatory markers after 24 to 48 hours. If there is persistence of fever, rising inflammatory markers, you may consider using steroids 1 mg per kg methylprednisolone. After making sure that you're not dealing with other conditions, as Dinesh sir said, rheumatological conditions, malignancy, you have to rule out other things, really rule out other infections, typhoid, malaria, other things, and then think about using steroids. Category 2 is fairly straightforward. You have coronary dilatation there, and your inflammatory markers are elevated, and so you start IVIG. And then IV methylprednisolone is recommended 1 mg per kg along with that per dose PD. Usually we give for 3 to 5 days. And when we give steroids, we don't give high dose aspirin as the way we give Kawasaki. So we give low dose aspirin 3 to 5 mg per kg per day for 15 days to 1 month. And IVIG 2 gram per kg. And if the fever is still persisting, that is called resistant case, you may give a 10 mg per kg methylprednisolone as a pulse. And still, if the fever is continuing, that is a resistant Kawasaki, you may think about a immune modulator like you can give infliximab. In shock, if there is shock, as I just now said, if the patient has received more than 30-40 ml per kg bolus and 1 or 2 inotrope requirement, myocardial dysfunction, then you give 10 mg per kg methylprednisolone as a pulse dose, so that cardiac contractility improves. Because if you give IVIG on a dysfunctional heart, it can overload the heart. So you give first 10 mg per kg of methylprednisolone, wait for 6 to 8 hours, let the contractility improve, then start IVIG, give 2 gram per kg over 2 days. Usually you don't need a second dose of pulse methylprednisolone. You may give 1 mg per kg per dose methylprednisolone on day 2, day 3, day 4 for the next 3 days and then stop. If there is a resistant shock, persistent fever, rising inflammatory markers, inotrope requirement is still going on, cardiac contractility is not improving, you may give a second dose of pulse methylprednisolone. This time, second dose may be 20 to 30 mg per kg of pulse methylprednisolone. And in that case, if that is not working, you may go for a immune modulator like anakinra or tocilizumab.
Yes, you were telling it very beautifully, sir. But when the child is presenting with shock, initially severe hypotensive shock presentation where he required albumin also, what you suggested of if it is a dengue with the COVID. Yes, that case is rather than going with immunoglobulin on day 1, we just waited. Yes, because fluid overload will be too much, so we need to wait for 1 or 2 days till it settles. Only then 500.
If the ejection fraction is less than 25%, better not to load with IVIG on first day. Give 10 mg per kg methylprednisolone. You may give IVIG 5 gram per kg, 0.5 gram per kg on day 1. Maybe that also after 5 to 8 hours. If the contractility is little better. I agree.
Thank you.
And if the ejection fraction is less than 25%, then better to start low molecular weight heparin.
One way dengue shock we can differentiate it is mostly it will be like a vasoconstricted shock compared to a MISC shock, which is more like a vasodilator. It's very difficult to
But in
differentiate.
dengue shock, we don't give IVIG.
Dengue also is not recommended.
Ma'am, this is for you. So with respect to resource, I mean, resource government hospitals, do you give all children IVIG or most of your children have been managed with steroids at 10 mg per kg? When you see MISC with shock and it's clear.
MISC with shock, definitely we had to give the immunoglobulins and it was available this year, especially from the last year, they made it available. Government made it sure that none of the institute will lack this, especially Gandhi being the COVID center, we were provided with all this. But without shock, we never started with immunoglobulins, though most of the studies considered, even at beginning also, with the perspective that the child may end up in that, or the condition may worsen to go with the immunoglobulins. So following guidelines, we went with steroid initially. Only with those cases where we had the shock, we gave immunoglobulins.
How do we, this is for all the panelists as well as Suchitra ma'am, all of us, I mean, when we define MISC, it's not always all these children fit all the criteria of MISC. They don't fit the textbook definition, be it WHO, CDC, all these guidelines. So how do you define MISC in your clinical practice?
Yes, to start with, we have to have that classical WHO definition, what they have given us, fever more than 3 days, and any of the remaining thing, at least 2 of them, clinical as well as a lab criteria, where the clinical criteria, we see multi-system involvement. Like GI presentation is common with abdominal pain, cramps, or loose motions and vomitings, or the child may have other respiratory findings also at times in the form of pneumonias also they may present. Mucocutaneous involvement may be seen, and cardiac involvement at times, myocarditis presentation. So with this phenomena as well as your lab parameters, you should have the CRP more than and ESR and your other parameters. If any of them, the criteria is fitting into, only then we consider. Along with this, because now the dengue has come into picture, it is becoming difficult for us to stay on, or because the coagulopathy is one thing, little tricky in both the situations. So that is how we are going with managing it. So this is
yeah, I think you put nicely. See, I think as Dr. Ajit has said earlier, it's a diagnosis of exclusion also. So it could not be your first diagnosis. So you have a fever. Look for what are the possible causes of fever first. Unless it's coming strikingly to you with someone is classical Kawasaki-like presentation fever in this COVID era, COVID antibody positive is probably yes. Or you have a child with fever with shock, COVID positive, dilated coronary is probably MIC. So these are very straightforward diagnoses. But your tricky ones are you having fever where you're not able to get cause, fever with dengue positive but not settling on with high CRP. These are your tricky ones. These are the one where you probably have to hunt for and rule out other causes of fever before you label them an MIC. That's my only sort of message. Once you have high-grade fever and high inflammatory markers, that is when you start considering. But very important for you to rule out all other causes before you label them as MIC.
We have seen one case last week wherein the child is around 9 to 9-year-old and she happened to have the same presentation and her vital titers were 1:320. In spite of starting her on first line of the enteric treatment, ceftriaxone was given. Second also we started. Because doxycycline also was considered. In spite of that, again on 7th day, still she is having high-grade fever. With a CRP around 30 to 35. So it is not coming down. So we were in a worry whether at what point are we supposed to start them on further management, whether it to take it as MISC or not. So particularly per se, fever with no focus. Any focus we get or any clues that we get from other points, then it is better to wait and watch for that. That's what we have.
I think in this current pandemic, post-pandemic situation, whatever we see, whatever we come across, patient looks like MISC. Everybody can be fit in the MISC. That's why exclusion of the other reasons it becomes really, really important. And when we were talking with the adult intensivists yesterday, it looks all similar, like it looks like all we see in leptospira. That's all we see in this. How do you come to conclusion of MISC? But then we have to look at the exclusion of things common cold infection, malaria, dengue, entering left rickettsial, and then look for the supportive evidences. I think the myocarditis, pericarditis, and the very high inflammatory markers for evaluate.
In children with MISE, when the initial 2D echo is normal, should we repeat a 2D echo the child, or what are the clinical indicators which would make us to think of repeating a 2D echo if the initial 2D echo is normal? And what is the role of aspirin, or how do we do all children need aspirin once we label them with a diagnosis of MISE? I would like to ask Arjun sir to comment on this.
Yeah, first of all, going out of suspecting MISC. The first phase had a classical MISC. Typically, the MISC unexplained fever, as Switzerland was saying, unexplained fever where no obvious focus is there, and two or more organs like cardiac involvement, a GA involvement, and unlike Kawasaki, these children are not so irritable. Unusually, they are not irritable. They're in fact they came to the bed and they're sick looking. So the high index of suspicion and ruling out other obvious causes that should be the take-home message. Regarding MISC, as you said, echo, we are strongly suspecting any cardiac dysfunction or patient has had shock. Better to always repeat an echo before discharging. The patient has been treated successfully. And likewise, obese children, high-risk category children, we have to have repeated echoes. Not to miss, like Dr. Farhan has been in presentation. Those with high risk category, one need to definitely do a serial echoes, and definitely coronary involvement or myocardial dysfunction is there. We have to have a day-to-day echo, bedside echo. And the role of aspirin again, we are really the markers are high. Suspecting Kawasaki like MISC, definitely aspirin, low-dose aspirin has to be given for 4 weeks.
You're
the right person.
Yeah, but Indian government recommendation is recommending aspirin
for all children, all phenotypes of MIS.
Ministry of Health has recommended all MIS should have aspirin low-dose for 4 weeks.
Yes.
Same thing. Our medical college also say low-dose aspirin for all there.
At least for 4 weeks.
2 weeks. Or at the end of 1 week.
The Ministry of Health has given guidelines for echo as well.
Because they sometimes have a direct.
Latest.
So they mentioned as 2 weeks, then 6 months, and after 1 year.
Yes.
Only those cases, especially where they have seen the dilatation.
Even if the echo is
with the cardiac involvement.
If echo is normal, inflammatory markers are high, they're asking us to repeat one echo at the end of 2 weeks. Especially like as Sir said, if the pro-BNP is very high, that gives a clue that there could be a coronary involvement later. And yes, aspirin has been recommended for all children once you've excluded everything and you've labeled them as MIS. So this child received IV immunoglobulin methylprednisolone, and as you can see, he gradually improved and he was discharged on day 6. And his inflammatory markers have gradually settled down by day 6, and he went home. So coming to the fourth clinical case scenario, this is a 13-year-old boy, obese adolescent, healthy child. He had high-grade fever for 2 days. He was lethargic and poor oral intake for 2 days. He had a COVID exposure 2 months back, and he was admitted at Apurva Hospital, and child was started on supportive care. In view of rapid deterioration in sensorium, he was immediately transferred to our hospital. At admission, he was very tachycardic, tachypneic. His blood pressures were okay. His peripheral pulses were felt. He was febrile with temperature of 103. The CFT was prolonged. He was encephalopathic with GCS of 10/15. Pupillary asymmetry was noted, but they were reacting to light. No obvious meningeal signs and focal deficits. He had to be intubated within 1 hour of hospitalization because of worsening sensorium and shock. Post-intubation, he was very difficult to ventilate. He required very high pressures and high FiO2 and conventional ventilation. Almost his P peaks were touching 40 and he was requiring 100% FiO2. On that, the blood gas, his PF ratios and OI were very bad, and he was saturating around 75. And during the peri-intubation period, he needed inotropic support and he was started on adrenaline. Bedside 2D echo showed severe biventricular dysfunction with ejection fraction of 25 to 30%, but there was no evidence of coronary dilatation in that situation. So as this child had refractory hypoxemia, he had to be shifted to high frequency oscillation. Initial settings were also quite high, requiring high MAPs of 28 and FiO2 of 100%. On that, also his PF ratio and OI had shown some marginal improvement compared to conventional ventilation, and he started saturating slowly, picking up his saturations, and saturation started improving with time. So these were his admission labs. He had a CRP of 56, high TROPI proBNP, a very high IL-6 level. His CBNAT was negative. His inflammatory markers like D-dimer and ferritin were high. The admission X-ray and the post-intubation X-ray, more of a bad pulmonary edema picture, and his platelet count was around 1.5 lakhs. So we have an adolescent healthy child who just hyperacute presentation and rapid deterioration. Within, I would say, 6 to 8 hours, he was in hypoxemic respiratory failure with severe biventricular dysfunction, shock, multi-organ dysfunction, and cytokine storm. So when we see such children with such rapid deterioration, how should we approach this clinical situation? This could be septic shock, this could be MISC shock with MODS, or this could be dengue shock with multi-organ involvement.
But in this case, as we discussed, pulse pressure was not narrow.
Yes.
And the echo which we did immediately at the bedside had congested IVC and poorly contracting heart. So the diagnosis was very clear. It was looking like more of MISC and less of septic shock. Because in septic shock, you can have myocardial dysfunction, but it will not be very severe usually. So when this child came like this, and there was a classical history of COVID also. So we decided that we will treat this as a MISC with type category 3. So started with the pulse dose of methylprednisolone, and then when the contractility was little better, we started on IAPTCB. And ventilatory support and fluid management and CRRT, all those things were started. This child was started on CRRT. The ferritin was 1,000 on first day. Second day, I think
it had gone up. So
37,000 or so.
So initially when the initial MISC guidelines were laid, people had said the first in 6 children with MODS and shock, give 30 mg per kg. But now, since the last 6 months, the initial dose of methylprednisolone when there is MODS or shock is 10 to 30 mg per kg.
So discussion for entire year we were arguing. So I was always saying that 10 mg per kg, there is no study comparing 10 mg versus that. But as madam has done a lot of research now, and a lot of literature, so she has also told me all the studies are now recommended.
All countries.
Yes.
Then you can stand up.
Yes.
There is ceiling dose as well, 1 gram.
Yeah.
Depending on the weight, even if you get a big boy, ceiling dose is 1 gram. You cannot cross the 1 gram.
The IVIG also has a ceiling.
IVIG has got a ceiling dose of 100 grams.
Yes. So this child both came positive dengue NS1 and IgM. COVID antibodies were reactive, and other infections like Vidal, Mealflix were negative, and blood culture was sterile. So 12 hours into admission, he was still oscillated, slight decrease in his MAP, but still requiring high FiO2. There was some improvement in his in his PF ratio and OI, and improvement in his saturations. Blood pressures are stabilized with the inotropes. He was requiring but 3 inotropes: adrenaline at 0.15, noradrenaline at 0.08, and dobutamine at 5. Urine output was less than 1 ml per kg per hour, and he was positive 900 ml since admission. He continued to have persistent fever. He received 1 dose of methylpred 10 mg per kg, and IV immunoglobulin was on full, was being continued. So at this clinical situation with someone with severe biventricular dysfunction, who is diurosing himself but not adequately, additional organ support in the form of renal replacement therapy, is there a role in this child? I would like Dr. Kapil to comment on it.
Yeah, if you look at this big boy with severe biventricular dysfunction, receiving IVIG, passing less urine, still getting into positive fluid balance, going to go into the fluid overload soon. Fluid overload, there is a pulmonary edema already. So fluid overload again comes with more of a cardiorespiratory pulmonary interactions, and is going to worsen his lung status. CRRT would definitely help him here, but more not for the good fluid titration, fluid balance. Along with that, it does also will help him. It's like in a cytokine storm, very high inflammatory marks will help in that decrease the azotemia and will have better control over the electrolytes and fluid. Probably yes, I think he's the right candidate to start on renal replacement therapy.
So, when there's always this doubt in the mind when someone is on CRRT and we are giving immunoglobulin, will it get absorbed on the filter?
Yeah, and there is always a doubt, but I think we have gone through that literature. It does not clear immunoglobulins as it is directly, at least not full to the 10-15% is been removed, but most of it is stayed in the system.
So it's almost third day into admission. Child was still being oscillated, but quite better. MAPs have come down from 28 to 16, and FiO2 requirement also has come down to 0.6. There was improvement in his blood oxygenation level with PF improving to 166 and OI to 10. And but still he was requiring 2 inotropes, adrenaline, and 3 inotropes, adrenaline and noradrenaline 0.08 and dobutamine at 8. On CRRT, and he himself was passing around 1 ml per kg per hour. We were able to have a good fluid balance with him. Still IVIG was being continued because he had to be given 100 grams, the maximum ceiling dose for his with respect to his weight. But he continued to have persistent fever. And these are his labs. As you can see, by day 3, the platelet counts have dropped to 50,000. His tropa and pro-BNP have shown a slightly downward trend. His IL-6 also has come down, but the ferritin has raised on day 2 from 1,000 to 12,200. And there's progressive leukopenia. So this is a small video of the child on day 3. Child is being
also except that the COVID positivity.
All other things are possible in the first day the child was in cytosol.
IL-6
of 569. Classical cytosol. But he responded to CRI.
What I mean to say, right? So, doesn't dengue cause this? Why? Just as corona is causing, SARS is causing.
Cytokine storm.
I know, but
so dengue causes cytokine storm.
any other virus also can cause.
Yes, it can.
Not only corona should cause.
No, sir. Dengue from last so many years it is causing cytokine.
Any T-cell mediated
So that is a
the virus.
Yes, sir. They are using the cytokines, cytosol and CRT for dengue.
Yeah, that's fine. That's fine.
For 5 years, sir.
Now we are labeling it as separate mist caused only because of corona. Why not?
There is cytokine storm can cause from.
At this point, Dinesh sir, is there any role of biologicals in this child? Day 3, almost IVIG is going to finish. Clinical conditions, some stability is there, but still inflammatory markers are high, high-grade fever, need for inotropes is still there.
Yeah, I think in this case, I'm not sure because persistence of fever, is it still part of dengue or is it part of MIC is going to be difficult to differentiate. The only thing is your CRP is rising. That is one thing you can see that your inflammation is rising, your ferritin is rising. These are 2 markers of inflammation. But your tropes got better, your pro-BNP got better. So platelets drop could be part of dengue, white cell drop could be part of dengue. And you could have a dengue child have mounting fever for 5 days. So in a dengue child, it's going to be very tricky to say what is the cause of fever. When you have a classical MIC, it is different. When you have, say, you given IVIG, given steroids, 48-72 hours, fever is persistent, that's when you start thinking is the role of biologics. So here, certainly you have so much sort of invasive, you have got central lines and other things in process. So you rule out infection. Certainly you need to rule out infection. You need to see whether you upgrade your antibiotics, look for all other possible causes. And certainly then once we are very sure that yes, this is MIC only which is causing, And that's when I would think, which would possibly be, your fifth year of dengue is over, and the probably dengue is not, your cultures are negative, there's no other focus of infection, and persist, and your CRP market is going up. I probably get an ESR also there. And then if they all are high, then I would say maybe biologics might help. So in biologics, you have, I know people have looked at which one. There are tocilizumab, infliximab, anakinra. There's no particular one which has been set one over the other. It is probably, but this is one place where you probably take your rheumatologist or immunologist, who is the person in your unit. Because I think even as I was showing you a Minister of Family Healthcare recommendation, they say do it under specialist recommendations. We, I think in our unit and even for Bangalore unit, we have experience of treating a couple of children with biologics who are classical MIC, who are having persistent fever. But yes, we can consider biologic. But in this child, I think I would be still trying to look for other causes before.
This child is having, this is the day 3. And actually, IVIG's full dose was also not
almost not.
So we gave 40 grams, and day 3 we gave 20 grams. From yesterday, the fever has settled now. There is no fever now.
I didn't continue.
What's the issue about biologics?
Okay, yeah, the last case. This is a 6-year-old girl. She's come from Bidar. She had a bad pneumonia in Bidar, so they did a CT chest, and the CORAD score was 18. So they gave her a dose of remdesivir and steroid, and when we were worsening distress, child was referred here. The aunt also was a doctor here. So at admission, she was quite sick. She was in severe respiratory distress. She was almost requiring 10 liters of oxygen, saturating only 85%, but she was hemodynamically stable, and she had severe hypoxemia. Admission lab showed CRP of 20. D-dimer was not that elevated. Mildly elevated liver enzymes. PCT was 21.4. And echo was normal. This CT was done in Bidar, which showed a CORAD score of 18/25. And she was started on HFNC, requiring very high oxygen and HFNC. ABG after 4 hours showed a slight improvement in her hypoxemia, slight improvement in her tachypnea. So at this situation, do we need to continue steroids and remdesivir?
I think I did mention in my talk about, what the controversies about steroids and remdesivir. Steroids should be continued only in moderate to severe sort of COVID illnesses if it is confirmed COVID. So here I think you need to confirm whether it's COVID or not. And now I think the peak of COVID season, summer was coming in middle of April or May. I think probably my approach would have been a little bit different. And someone coming now probably a little different, but I think 18/25 is a huge score. But I know you need to look for other viruses also could be a possibility which you should think about. But steroids in children, again, there's a very clear recommendation is only used for, worsening respiratory distress, increasing respiratory support. Remdesivir, there's a clear recommendation not to use in children at this stage. Again, I would say, I won't say that it's been completely etched in stone, that maybe the recommendation might change over a period of time. In children with in less than 10 days, worsening distress, on ventilator, they might think. But at this stage, in this child, I think I will hold on and try to see whether it really meets it or not. But I think you have put in from Mr. Family said clearly it is not recommended in children.
Thank you. So this child CBNAT turned out to be negative. Arjun sir, what would be our approach now? Looks like a COVID pneumonia but CBNAT is negative.
You have to keep other things like H1N1, so-called swine flu that we used to have earlier. Now everything we are centering around, focusing around only COVID. The other causes of viral pneumonia, maybe viral panel can help us to identify. Again, the reporting of CORADs, earlier such a thing was not there. Don't you think that there were no GGLs earlier, the ground glass appearance? Other illness. Yeah. So consider possibility of other illness like influenza, ALP, H1N1, adeno, and as you rightly said, the respiratory panel will definitely. I would definitely like to use more of a fluid oseltamivir as first line before considering remdesivir. So only high risk category like obese children, adolescent age group, maybe remdesivir is differently useful. But I'm sure fluid is oseltamivir is more useful.
So recently in JAMA also they published a difference between COVID and influenza in children, and they found out that early lung involvement is more in influenza compared to COVID. And GI symptoms are more common in COVID compared to influenza. And inflammatory markers are more high in COVID compared to influenza.
So, and more important, the supportive treatment, especially oxygen inhalation, should be cornerstone instead of pumping in more drugs.
Yes. So this child's, as Sir said rightly, we sent a community viral panel, and influenza B was positive, and some, Pseudomonas staph also come positive for this child. H1N1 was negative. Child required HFNC for almost 8 days. She had bad ARDS, and day 3, day 4, in view of persistent fever, hypoxemia, and radiological shadows, her antibiotics had been upgraded. On day 9, she had improved, and she was moving to low flow oxygen, shifted to ward. So just a few to sum up with all the discussion we had today. In the outpatient setting, when we see children with unexplained fever, and we have ruled out other causes, and if there is a presence of mucocutaneous involvement and abdominal pain, I think we should look for both MISC and dengue. In the outpatient setting, we have unexplained fever for 3 days and evidence of inflammation in the lab, but child is otherwise well, and there's no indication for hospitalization. It's always better to repeat the labs in the next 24 to 48 hours. Not all children will fulfill the criteria of MISC. When we see children with shock, MISC, we see these different spectrums. MISC, where there's only fever and hyperinflammation. MISC with shock, they can have multi-organ dysfunction or only shock. And MISC with KD. All critically ill children, still the standard approach is it holds. Give fluid resuscitation, antibiotics, send your workup, admit them in intensive care unit, and provide good supportive care. Always look for your tropical infections and possibility of co-infections with COVID, dengue with COVID. Always consider that possibility. And children presenting with shock when there's a wide pulse pressure and they fulfill the first tier of investigations criteria for MISC, always consider doing a 2D echo for them and tier 2 investigations. Difference between MISC KD with KD, which is not related to COVID. These children with MISC with KD, they normally have some GI symptoms or neurological symptoms. They have some shock, they have some cardiac dysfunction, they have higher CRP compared to children with KD who do not have, who have KD which is unrelated to COVID. And presence of COVID antibodies does not rule in or rule out MISC. And as rightly said by all our panelists, MISC is a diagnosis of exclusion. With this, I would like to conclude and thank all the panelists. Thank you.
Thank you for the wonderful CME that we had. I'd like to thank the management and the academics of Rainbow for doing this CME very timely and in the hour for this epidemic. Since it's quite late, and also we have a program in the evening where we are Sir? Okay. Yeah, there are a couple of questions that will be answered, but I'd like to invite on behalf of the team of Medicon 2019 and 202 for their time. The evening for the board. Thank you. Dr. Farhan can invite us. Online or it's physical. Thank you all.
Thank you, sir.